Hello, hello. Nobody here has worse English than me. So this is gonna be like a Spanglish morning. Don't be worried if somebody wants to ask anything. Please. I don't care with Dr. Salvi. He knows me. I don't know how he understands me. I don't have idea. So we are going to show at least 8 cases. We are going to have a break in between. The cases are everyday cases. No sophisticated, I don't know, fancy cases, no, everyday cases. And the way that it's going to be is one of the fellows present a short clinical story, very, very short, and after that, the images. It's going to be an answer system, and somebody's going to explain it, and you vote that you think is the right answer and question, okay? And after that, the master is going to have his insight. We have a very small discussion. Again, if somebody wants to speak in Spanish, be free, no problem. I can translate. So let's begin.
So first, we would like you to download or to take a copy of the QR code so that you can be redirected to the web page where we will have the questions linked. And for the dynamic of the exercise, first, well, as Dr. Salazar well said, we have 8 cases upon which we are going to show you the clinical history of the patients, and we're going to show you the images without having a lot of detail upon them, well, without describing the details about them, so that you can, well, as well-trained you are, you can observe the images and make your own opinion without our interference. And then we're going to make some questions about the case. Ses. Sí.
Good morning. Welcome everyone to our session today, and we are very happy to count on Dr. William Zoghbi participation today. The clinical case number 1 is a 77 years old male in status post ABR in 2016 with unknown dimension and baseline gradients. Cabbage with unknown anatomy at the same date, actually asymptomatic. Studies were performed as part of postoperative follow-up. On the physical examination, his vital signs were normal and mid-systolic murmur was found at the right upper sternal border. TT images we performed 6 years after surgery in March 2022. These are LV projections, and measurements are depicted in the table. Please watch carefully. Okay, again, There are LV projections and measurements are depicted in the table.
We have plenty of space here. Maybe you don't see well behind.
Yeah.
Okay, these are Doppler evaluation. We found the following measurements. Remember that the prosthesis was unknown. We don't have reference values of the prosthesis, and the baseline echo was done in another hospital. Okay, please enter the app in your cell phone, answer the question number 1, and submit. Okay, would you request any additional study? The winner is option B, yes, TEE.
Okay, Dr. Zoghbi, so most people think that with that information, the transfer is not known, and the patient must need a TEE. So what's your opinion?
Okay. You put me on the spot. Good morning. Number one, before we talk about the cases, I want to thank Dr. Salazar and all of you for the invitation. It's a pleasure to be here, interacting with you, getting to know you more, and our home in Houston is open for you. So whenever, don't come all together, just one or two at a time. And I'm very proud of what Dr. Salazar has built here. The facility, the quest for excellence, the teaching, and I know Hector asked me to stay another day. Willingly, I didn't think twice. The only thing was in the equation was whether it is on Halloween's day, because I need to be with my grandkids. And it was not, so I stayed. This is a great case because, in a way, actually, you can live with a transthoracic without a TEE in this situation. Let me tell you, go back to the first slide, which the first one, go back. And I'll tell you, without knowing anything, go back even one more. Yes, play them. And let's see how we interpret this situation here. We know we have most likely a bioprosthesis valve without even seeing the Doppler. The Doppler helps you. You're not imaging the leaflets, but I would infer that most likely it's a biological valve as opposed to a mechanical valve. You would like to see a short axis at the level of the valve a little better, but maybe the shadowing is stopping you from seeing the actual leaflets inside. Okay? So that's my first impression when I saw that. The second impression is that the aorta is enlarged. Not huge, nothing to intervene upon in somebody who is, 70 some years old, right? And had the surgery 6 years earlier. That's okay. I like to point with my hands here. Ventricular function is good. Although this patient had a coronary artery bypass surgery, I don't see flagrant regional wall motion abnormalities. So in somebody who's asymptomatic, that's my recollection, I think it's not a bad, I don't know why he came to see you and not seen in between, but that's the initial impression. Next. On this one here, you see barely a trace aortic insufficiency. What you see is pulse Doppler
with a very nice velocity and velocity time integral, so you know it goes along very well with what you saw on the image of 2D, meaning that systolic output is very good into this valve. When you look at the CW, I don't see clicks. It goes along again with a non-mechanical valves. So it is a biological valve with a high gradient. The gradient is higher than you would like. And now, when you see a high gradient, you have to wonder, is the high gradient because of a high output situation? Is it a small valve or is it a stenotic valve? These are the things that would go in your mind, right? Now, most likely, and I'm almost sure, just even without me using calipers, and that's how I'm almost sure that this valve is a very decent size valve. Is at least probably a 23 valve, and it could be a 25 valve, millimeters I'm talking about, which, if it is that large, should not give you this gradient. So my inference is that I'm dealing here with a valvular stenosis 6 years down the line. Now, interestingly enough, patient is asymptomatic. Are you going to change your management at this time if this patient is asymptomatic and I don't see anything in the history that would lead me to intervene, right? Ventricular function is good. I don't see much hypertrophy. I would follow this individual just like you would follow somebody with almost a native valve, knowing that the prognosis usually gets accelerated once you have some stenosis. Okay? So going back to your question, do I need a TEE? Yes, no. It is a bit academic. Okay? And the reason for it is, what am I going to get with the TEE? I'm going to be able to see the leaflets of this valve, and most likely I'm going to see some calcifications. Now, is it going to change my management? Not necessarily at this stage of the game, because what we talked about. So, unless I see something else, to tell you the truth, I could be satisfied with a transthoracic examination in this situation, not pushing me to a further investigation that doesn't going to change anything else. Is it good to know? Tell the patient if I see you. So I go in between. If this is a patient of mine, I would just tell them that there is most likely this valve is starting to narrow 6 years down the line, and we're going to watch it. And we're going to watch your symptoms. And if you start having some symptoms of dyspnea, or if I see the ventricle going down, then yes, I would need more investigation and most likely an intervention. And nowadays, conceivably, you could put a valve in valve at this stage of the game. So I would personally go without a transesophageal echocardiogram, going from what I'm telling you that it will show. So I'm going against the majority. All right. And I'm suspicious that you did a TE.
Question.
Yes.
So this is knowing that if you would be your clinic patient, but on the report, your report would say elevated gradients would need further imaging depending on symptoms, or because the gradients are definitely high, as you mentioned, it could be high flow, stenotic valve, or stenotic since the beginning.
I think this is a stenotic valve. A stenotic valve in a dynamic situation. The stroke volume in this patient with the hyperdynamicity that I see is at least about 80-85 cc's. You see what I mean? But it is a stenotic valve. So the way I would report it, and I would leave it to the clinician because usually we don't know the clinical history, etc. behind it. I feel comfortable, said there's a high gradient, most likely this is a biological valve and it's stenotic. That's what I would do. Now, the clinician may have a little different thing. If the patient, now you could put this individual on a treadmill and see if they huff and puff, but remember they're 76 years old, right? So their exercise tolerance may not be as good as you and I. And usually we're gonna go by symptoms and depending what the situation's here. So actually, that's what I would do. I'm not even gonna suggest an MRI. And then the other question is, if you do an MRI, what are you going to get? If you do an MRI, you're going to be able, because it's a biological valve, you're going to see the valve leaflets, and you're going to measure them, you're going to measure the stenosis. At times, you may have artifact depending on, the struts, et cetera, So this is where, if you need further information, you have to decide which methodology you're going to use. I personally, in these situations, I would use a transesophageal as opposed to an MR, because there is no other things that I really need for an MRI, which is flow quantitation, assessment of the ventricle, LGE, all the other things. So you always have to decide on the crossroad which one's going to give you the information that will help you in diagnosis or management or both. You agree? Any questions?
We'll agree with what everyone else said. Go ahead.
Okay, let's continue the case. A TEE was performed to evaluate valve morphology and to explain the elevation of gradients and velocities. These are TEE images of the bioprosthesis in aortic position and color Doppler examination. Okay. The geometric aortic valve by 3D planimetry was 0.9. With these images and measurements, please answer the question number 2 in your cell phone and submit. The most likely diagnosis is...
Need the new operator, maybe.
Okay, the winner is option A, prosthesis patient mismatch.
This is not patient prosthesis mismatch. I don't know, if you measure, actually another thing is that you can measure, you don't know the story on this individual, but with TEE and even with transthoracic, you can measure and have an idea what is the size of the prosthesis based on, you need to know that measurement of sizes, when you say a 21 millimeter valve or 23, usually they're odd numbers, 21 or 23, etc. These are the outside border of the sewing ring. So if you have either mechanical thing, so it is actually not the inside of a valve, it is the little bit of the outside of the valve. So I bet you if you measure here, and you don't have to have a computer, you could do that by calipers, by your hand, by whatever it is. It's a large prosthesis. It is not a small prosthesis based on what I told you before on the transthoracic and what you measure here. But notice though that this leaflet is not as good as the other leaflet. Its excursion is not as good, and it is thickened. I'm not sure it's calcified. I think it's thickened with reduced mobility. You could see it here, but actually on the color Doppler is better as opposed to the transthoracic here, right? To the long axis view. And the short axis is a little more difficult situation for you to see it. You can see an opening. When you measure a cross section of a biological valve, it is tricky. Okay? Why? Because you need to have a good sweep of the aortic valve itself. Remember, the stenosis, if there is a stenosis, is not very distinct in one plane. Never is in one plane. Even native valve stenosis, difficult, right? So you have to sweep And you could do that by pulling the probe back and forth, whatever, sweep through the aortic valve and find the smallest measurement of cross-sectional area. What's difficult here is that this valve is restricted much more at the base. So it's a little tricky. A physiologic assessment is probably better than an anatomic assessment. Having said so, you don't have much of a discrepancy between what you measure here of 0.88 or 0.9 and the physiologic assessment of effective orifice area. All the Doppler is effective orifice area. Why? Because geometric measurement is always larger than an effective orifice area, always. It could be by 0.1 centimeter squared or something like this. For those of you who still do a Gorlin equation, right? When you go to cardiac catheterization, et cetera, some of the factors actually are to correct for that change from anatomy to physiology, right? The C for aortic valve is 1 as opposed to a mitral of 0.85. So I see personally that this valve, portions of it are functioning well. There is at least one leaflet that is much more restricted, thickened. Not too unusual at 6 years in an individual, because we know that most of these valves on average last about 10 years. Unfortunately, some of the newer valves, I don't know what kind of valve he was put in, like the trifecta valve is very erratic. And if you look at the literature, the trifecta valve has a higher incidence of stenosis degeneration earlier than 10 years. So you have to kind of be careful about those situations. And so I would tell this individual that the valve is starting to degenerate. And remember, this is not new information compared to the transthoracic that I told you about. And we'll follow this individual maybe first at 6 months, repeat an echocardiogram just to see what happens to the gradient. And then certainly every year, because the gradient is going to get worse. The problem here is not regurgitation, is much more stenosis. And he may have significant pressure overload. What's not helping this individual, not to say to take it away, is that his output is very good. That's why he's generating such a high pressure of mean gradient of 40. And you don't want to intervene just too early on this individual. So you watch them closely and you tell them what symptoms are they going to look for, mostly exertional dyspnea or rest dyspnea or chest discomfort or something like this. Any questions?
Do you have a threshold for imaging the aorta? Say the aorta is 45, 47. You would?
No. At 50, obviously, you start thinking about both. When do I intervene and see if the aorta is getting larger? I doubt this aorta was small at the time of insertion of the leaflet, and you know why? Because this prosthesis is large. Most likely, it was a large cohort of aorta in addition. So, from your transthoracic or TE, I would have peaked, obviously, at the aorta, make sure all the other aortas are not too bad. If there is a suspicion, I would do an MR for that. But at this stage of the game, my visual caliber was the aorta was about 3.8, 3.9 at most. So.
Why MR and not CT?
I'm sorry?
Why MR and not CT?
Why an MR, not CT? Because also at the same time, I can have hemodynamic assessment. CT is not going to help me more, actually.
Because of the complementary role of MR.
Yes.
The AI is not just trace.
If, the other things that go into mine, it's not going to give me much more, meaning a CT is not going to give me more information. I don't have to use dye in a 76 years old. I don't know which is more expensive, and you have to think about this. What is the patient going to get? Not only from you getting the information, is what are they going to be stuck with? If I'm practicing somewhere where it is self-pay, you have to be, if it is self-pay, to tell you the truth, I won't do any of this. I would get stuck with my thoracic examination because I know the information already. I know what I need. And I'm gonna look for progression of the aortic stenosis till the patient has symptoms. And then also you have to weigh this patient's comorbidities. This guy looks like he's otherwise doing well. But if you have comorbidities, other things, if you have some renal dysfunction, the acceleration of this valve is much more than if somebody has no renal disease. So you have to know the whole milieu of the person.
So, you know, in mitral stenosis, the planimetry, the assessment of the geometric orifice area is almost the gold standard in mitral stenosis. My question is about the aortic stenosis, and in this patient, the prosthetic evaluation. Do you think the measurement of the planimetry of the prosthesis, or sometimes when you have antivalvular valvular disease, has a role, or?
I think it has very little role, to tell you the truth. One is because, particularly in prosthetic valves, at times you have a lot of shadowing. Here you have a beautiful things that you could do. You could do the measurement. The problem is, again, is where is your cross section? At times, most of the time, you'll overestimate what the valve area is. Why? Because you have to be really at the tip of the valve and making sure that you have all of it, right? And it's not all in one plane. So if you're just below the stenosis and you measure that, it's going to be a larger area. That's why I usually go for physiology. The role of measurement, to me, is if I have a sequential stenosis and I'm not sure, right? Like if I have a dynamic LV outflow gradient for whatever reason, either a little SAM, hypertrophic cardiomyopathy, other things, and then there is a sequential lesion. I'm not sure about, I really need to go for anatomy because physiology cannot help me, right? So it is only to substantiate the diagnosis. There were early days from Nat Pandian and others, and on calcific aortic valve, trying to look for the measurement and see how accurate it is by transesophageal echocardiography. You know that you could almost dial in your valve area by decreasing the gain and other things because of ballooning of calcifications, what it does to. So it is corroborative. If I have a problem with Doppler, I corroborate it. But if I want something and I can't get a good Doppler examination, I will do an MRI. Then I get both. But I need physiology much more than anatomy once I know what the process is, what the disease is. Yes?
Do you usually include the size of the prosthesis? I mean, the measure that you obtain, I guess, in the red vessels projection?
I usually don't report the size of the prosthesis from our measurement. I try to get as much information from the patient. They usually carry a card when they come, I don't know, at least in the United States, when they had the surgery. And nowadays all is electronic, so one time you put it in for Mr. X, next time they come in, the information is already there, so you don't have to dig for it. The only time I measure it is just like this case, I don't know much. I want to know whether this could be a prosthesis mismatch. Is this a 19 millimeter valve, which will give me hemodynamics almost identical to this valve, right? So this is where I usually measure it, just try to figure out. In a long axis projection. Yes. And you need to, we usually don't, really, I think. It just helps me know whether this is a small valve, yes or no. But you corroborate it then with the motion of the valve leaflets. If the valve leaflets are completely normal and it's a smallish valve, you know you're dealing with prosthesis mismatch. Yes.
So you have to give it a little, maybe about 2 millimeters, 1 or 2 millimeters in the white echogenic area. At least it will give you an idea. And you want to make sure that, but I don't report them. This is only when I want to know. I don't have anything else, whether this is a smallish valve. Yes, sir.
So this patient has a rate meter that is acceleration time. So the time was 85 milliseconds. Do you think it's important this measure for define, for example, valve stenosis, prosthesis, and mismatch?
I would refer you to a paper from our lab. First author is Zoghbi MD. Okay, Sagit was a fellow with us for a couple of years, and she's back and she's the head of a lab in Israel now. Interestingly enough, acceleration time also, remember, if you have a small valve, it's like a pseudo-obstructive. So the gradient is higher, ejection time is a little higher, acceleration time is a little higher, than less than 80 milliseconds. Acceleration time, just like any other measure, if you take a single parameter, is not very accurate, meaning that there is a zone where you don't know. Usually less than 80 milliseconds, you can almost take it to the bank that it is a decent valve. Greater than 130 milliseconds, you could take it to the bank that it is a stenotic valve. In between is a no man's land, meaning I want to make sure that all the other parameters fit in. Like in this case, it's a stenotic valve. Your early acceleration time is not very rounded, right? Somewhere in between. But I know the valve area is close to 0.7. And remember, any of these measurements, they have an error of about 0.1 centimeter squared. Valve area could be 0.6, could be 0.8.
Okay, let's continue.
Right? So.
The patient remains asymptomatic and under medical management. Now, let's see clinical case number 2. The clinical case is a 74-year-old male admitted for dyspnea and low moderate exertion and lower extremity edema. In status post ABR, perimount 23, cavage, and ascending aorta supracoronary reconstruction in year 2020. Past medical history included high blood pressure and chronic kidney disease. Vital signs were normal with a mid-systolic murmur at the right upper sternal border. These are Doppler evaluation on the second day POP in the year 2020. The baseline measurements are depicted in the table. The images lack electrocardiogram trace due to protocols used in the COVID-19 pandemic. The effective orifice area was not calculated due to a limitation of the acoustic windows in the POP. And the bottom, we see the reference values of the perimount 23. 2 years later, we evaluated him at La Cardio with TTE. These are LV projection and measurements. And these are the aortic valve projections in TT. In this slide, we show a Doppler evaluation. The measurements appear in the table. Okay, please answer the question number 3 and submit. The most likely diagnosis is okay, the winner is option C, AVR dysfunction due to stenosis.
Interesting, because you have 3 possible choices. And so anybody wants to give us his opinion about the answer? Or let's talk
Whoever voted for the majority.
the majority, yes.
Whoever voted for them.
You're very shy today.
Oh, no.
Okay, no, so Dr. Zoghbi.
No, I mean, it's important for you to voice it because it should not be a one-way directional meeting, right? Why do you think this is a dysfunctional valve? That's the majority, I think I would say. I understand. No, entiendo un poco de español. No? Did you have your coffee this morning? Well, there is concern on this valve. And you could say, my goodness, within 2 years, could there be progression? I'm not sure, to tell you the truth. I'm not sure. And the reason I'm not sure is that the first study was done during COVID, was pretty sure accelerated. Whoever did the study wanted to just get in and get out and do limited, evaluation. But if you take a look at that peak velocity from, the previous one, was about the same. Now, go back maybe one more.
Okay.
Yes, this one here. I mean, this looks decent. It is not complete, but it looks decent, meaning, I don't know, I can imagine maybe a 2.5, maybe 3 meters per second. For yourself, if I'm, doing comparison, one thing that may help me differentiate that, meaning that is there a progression of prostatic stenosis, which is unusual within 2 years or no, is I would look, because this one looks decent for flow, what I would do is I would measure ejection time. This ejection time, and if indeed for similar flows the valve is more stenotic, ejection time is longer. So that's an indirect way. Actually, we have a paper many years ago with somebody that you may know. Somebody that you may know is not in this room. Okay? Is Dr. Augusto Galan. And I know the name rings a bell for you guys here. He's the brother of your previous president candidate, etc., etc. And he spent a year and a half, 2 years with us, Augusto, a very smart person, and did quite a few of the work. If you Google or do PubMed, quite a few work on aortic stenosis. So this is native aortic stenosis. And in native aortic stenosis, which I would think would be almost the same for biological valves, is if you take a look at the ejection time, and in aortic stenosis severity, ejection time starts getting longer for the same degree of flow. And you could predict what is the ejection time is for the normal situation, okay? And see if there is a delta between that. So I'm not going to belabor that. But the point here is, I'm not sure that this one was a very accurate measurement. I could look at what happens to the ejection time, and I'm going to do my good old dirty way of doing things here. And this is, it's like, what is it here? So each one of these is 1 second, 200, 400, 6, 8. So each one of these is 200 milliseconds, right? So I do this. That's 200 and about 30, 230 milliseconds. Can you show me the second one? More? More? Yep, right there, stay there. $265, 270. So it's longer. So that's my suspicion that this is real, but because I don't know whether this is real, yes or no, I need more information. This is too much of an acceleration, and as opposed to your first case, this is probably a very rapid acceleration. Another thing that tells me that there may be something wrong with the valve is I'm starting to see aortic regurgitation. It's not significant because your parasternal window actually was pretty decent, but it's just telling me that there is something not too well about this valve. So it is most likely an accelerated stenosis. Now, they mentioned chronic kidney disease, etc. I don't know how bad it is, but that could be an influential kind of situation here. So I will stop there. I would need more information. But I agree with the majority this time that most likely this is not a normal valve.
One question about a technical issue. What is the clue to have a really good pulse Doppler? I mean, the LVOT pulse Doppler, because we have here two differences, and it depends on where you choose, the measurements are completely different. So what is the clue? When do you have to do, or when you are really sure that that envelope is the right one?
Usually, the problem is you can put your pulse sample volume in different places and you want to know where is the correct one. If you're too deep into the LV outflow tract or more apical, the cross-sectional area is bigger, so the velocity is lower, right? And if you're too close to the valve or inside the valve, the cross-sectional area is smaller and the velocity is larger, okay? But one thing that we know we should not do is the inference. If I have two clicks, see this click here, and I have another click here, I don't see it. You should not have two clicks. Why? Because remember one thing, during contraction, the heart descends towards the apex, right? So if I start in the LV outflow tract and the heart descends, then my pulse sample volume could be close to the valve and I can record a closing click. If I'm recording both an opening click and a closing click, meaning my sample volume is already into the valve and you should back off. Here, there are two things that tell me I'm most likely okay. One is the closing click alone. 2, I'm still recording a little bit of aortic regurgitation, meaning I'm below the valve. So I'm happy with it. It looks good. We don't correct triangulation. I think you should, whoever is doing it, a nurse, sonographer, physician, make sure that you have the highest velocity at that location. So you decrease the angulation as much as possible. And this looks pretty much, remember, another thing that I mentioned in my lecture 2 days ago, these numbers combined with your cross-sectional area have to make sense, right? When you derive your stroke volume, it has to make sense with what the size of the ventricle is and what the function of the ventricle is. When I look, and I think that comes with experience. Obviously, early trainees are not going to do that, but go back a little bit. One more. To the ventricle itself. One more. There you go. All right. See, when I interpret a study, I look at everything and I semi-quantitate in my mind what the situation is. So I'm looking at this heart. This heart's about 4.5 centimeter in diameter or something like this. I know the ventricular size is going to be about 120, 130 cc's based on my knowledge and quantitation. And if I have an ejection fraction of about 60%, my stroke volume is about 75%, plus or minus 10. So if, go back forward now, forward. And if I get a stroke volume of 40 for whatever reason, or 85 or 90, I know there's something wrong. So you have to use all the as much information as you can to make sure that you have to verify and double check your measurements. Okay? So let's see, you want to proceed? I'm pretty sure you have another question here.
They showed us a stepwise analysis of the valve when they might have dysfunction. Going from measuring the velocity, then the gradient, then trying to measure the effective orifice area. And would you put this calculation of the time on the stepwise analysis for a dysfunctional valve?
Ejection time?
Yeah, the one you just measured.
We don't have really, the problem with the ejection time is also dependent on stroke volume, right? So if you have a depressed ventricle, ejection time goes down. Actually, if you want a formula that you keep in the back of your mind to help you, of what is, it's 2 times stroke volume plus 106, okay? So that's your predicted ejection time of a ventricle. And that was derived many, many years ago. I'll give you an example. If my stroke volume is 50, 2 times 50 is 100, plus 106 is 206. So that's my usual predicted ejection time. And if my ejection time is much longer, more than 60 milliseconds more, I have an issue with stenosis. So that's what I use. It's not in the guideline, it's not, it's not anywhere there, but it is in the publication. What we use more often is the shape of the jet, and the shape of the jet incorporates 2 things. One is the acceleration time, and the other is acceleration time over ejection time. The reason why I rely much more on acceleration time is because in situations of tachycardia, ejection time goes down. You see what I mean? And then that ratio is altered. The acceleration time is not altered. So that's why I put a little more emphasis on that, but take a look at it qualitatively. It goes along with what you see.
Okay.
And also, Dr. Salazar will tell us that here making an error in the place where you measured can make that significantly worse when you make the calculation. So do you take any, or can you give us like any tips on where to measure or how to try to measure and make it more reproducible and making those errors less frequent or less grave, perhaps? Like when you measure the LVOT tract or the annulus, if you miss it for 1 or 2 millimeters, then you multiply that by.
Understand, but remember, annulus measurement, we don't have a case, both of these are prosthetic anyway, but annulus measurement is just below the annulus. So for a prosthetic valve, it's just below the insertion. At times you may have a septum that looks like coming into the LV outflow tract, forget about it. You got to go up high because you have to think 3D geometry. 3D geometry of the septum is just one tiny little area and the whole cross section is not affected by it. Similarly to when I talked about aortic stenosis 2 days ago, if you have calcifications, you have a lot of calcifications, you don't use the LV outflow tract. You can't. So in early systole, after about 2 or 3 frames, valve is open in a native valve. Just below the annulus, if you look at our first paper, when I was in your shoes, 1986 circulation, this is where the derivation of aortic valve area circulation. So that's one. We talked about where you put your pulse sample volume, and it's as important from an error point of view as your diameter measurement. CW is the least error, to tell you the truth. Although in the past, when I was in your shoes, we said, oh, CW is the biggest error. And you know why it's the least error? Because the number that is derived from it is very large. So if I look at a VTI of an aortic stenosis, usually it's about 60, 70, 80 cms, right? The other numbers are much smaller. So if I make a 5 centimeter error, it's not going to affect it that much. So your two major, yes, you have to do CW from all the windows and, take the highest. And the fourth error is making sure that you're matching appropriate beats. We talked about atrial fibrillation in the course, right? So if you have somebody in atrial fibrillation, this is either you take max, or you take a preceding RR interval to match it to your CW, right? You have to have the same filling of the ventricle so that it ejects next time and gives you the ejection time, the acceleration time, the gradient, and everything else. Does that answer it? Yes. Good.
Okay. The concept of our group was to perform 2EE. TEE as a complementary diagnosis tool. The acoustic windows in TTE was limited. It was not possible to evaluate the mobility and morphology of the aortic bioprosthesis lift. These are the most representative images of the TEE. Okay.
Go back if you don't mind. Was it being offered in that Give them some time to
think about what they're seeing.
Okay. The question number 4 is, do we need additional images? Okay, Dr. Zoghbi, do we need more images?
I need to put this in the clinical context. Go back to your TEE. Do you think the TEE is normal or abnormal
for a prosthetic valve? Raise your hands. If you don't want to speak, raise your hands. Normal. How many? Nobody's normal. You're not. I mean, you're not abnormal. Huh? How many think it is abnormal? Okay. And the others have no opinion, or? All right. Okay. Tell me on these four images, which one is abnormal? Left upper? Normal or abnormal? Raise your voice, guys. I mean, you have to be interactive. I'm not. Huh? Normal or abnormal? Abnormal. Normal or abnormal? Normal or abnormal? Kind of normal. Normal or abnormal? Abnormal, really? Okay. Personally, I was most impressed with the first two. The others, you know, the little fluttering that you see of the valve here is okay. You know, depends on the fluttering. The one on the right, I don't see abnormality really. I don't know what you see as an abnormal here. These are the struts of the valve. But it is a definitely abnormal valve. And the first abnormality is probably the most impressive. And interestingly to me is that this valve has a lot of mobility as opposed to just stiff for an aortic stenosis. The other one could be foreshortened, and that's why, but it is, see those? This, I should see some mobility of these leaflets of the valve, and I'm not seeing them. Now, this could be a pseudo abnormality. Why? Because this cut could be tangential as opposed to in the middle. And if you're more and more tangential, you're not going to be able to see the full mobility of the valve. Now, you could say, do you need more information? I would love a little more information, okay? I would love a little more information. Let me tell you, from a technical point of view, if I'm doing the transesophageal echocardiogram, I will try to either go further into the esophagus and look a little bit below so I get away from the shadowing of the struts, or pull back and look down so I can see the tips of these leaflets. And I would do that for both long axis as well as short axis. This is most likely, this one here, is most likely a little too high. I'm still seeing the struts. I'm just not seeing the whole thing, but I'm pretty close to be able to see the other abnormality that I saw. So I'd like to do a scan and try to get away as much as possible from the shadowing of the struts for me to be able to see the valve and play around. At times, playing around can be transgastric, a lot of retroflexion to see the valve from below, and you play around with that. There are different ways of doing it. And the question is, do you need more? Okay? I'm not sure I need more than this transesophageal echocardiogram. Yes, you could get an MR. You may see the valve a little better. But what I need more is actually, I want to make sure that this patient is not infected, okay, with a maybe a silent endocarditis or something like this, because there is some AR and there is some says AS, is dysfunction of the valve. And if the patient is symptomatic, at some point in time, something is going to be done. So that's what I would do first.
And if it becomes to an intervention, patient becomes symptomatic, and you're considering a valve-in-valve. Unfortunately, this valve prosthesis is not very large, putting it in. You have to think of what happens if you put a valve within a valve, what happens to the gradient, etc., etc. Conceivably, you may want to do an MRI to see if you could see the valve even a little better, with the caveats that you may have some artifacts, right, from the MRI.
Okay, extended protocol TEE images at 150 degrees. These are the images and quantitative measurements. Final diagnosis of mild to moderate regurgitation given by bioprosthesis dysfunction. Dr. Zoghbi, the regurgitant fraction is mild or moderate? Any comments?
Can I ask you, how did you calculate your regurgitant fraction? From the transthoracic?
TEE, doctor. Pulmonary valve.
Maybe some of the measurements are done by
Between us, right? You cannot do these measurements from a transesophageal alone.
Okay.
Right? Because unless you do a pulse Doppler in the LV outflow tract from the it's a combination of things for you to be able to do this. Cannot be from the TE alone. From the TTE. Got it. All what it tells me is I have problems. The AR is most likely moderate with these kind of numbers. I would like to know what the systemic output is like. I think it's not mild, definitely. For AR, if it is true, 30 and 37, this is a solid moderate regurgitation. And you could see that actually. See how eccentric this jet is? The first one you didn't see it, now you see it, because you have to look around. And I can't measure a vena contracta. See the shadow? See that? You could stop it, I don't know. But whenever you see a linear thing in the heart, there's nothing linear in the heart. Right? So this is a shadow. You can see how it may trick you. See how linear this thing is? Yes. And this is attenuation from this prosthesis. So you can't see below. Now you could, just like we talked about, go down a little further, look down. You don't have to be in the stomach. You can go down a little further or go up a little further. For AR, you have to go down a little further. But what it's telling me is within 2 years, this individual has significant dysfunction of the valve with stenosis and regurgitation. Most likely the flows are not just too high to give you this high gradient, right? So there is an element of stenosis that we're not able to see well. So it's a combination. Stenosis regurg, moderate regurg. And it's interesting that you didn't hear the regurgitation, but at times you may not hear it on the physical examination. So this is an unfortunate patient within 2 years having dysfunction of the valve. What did you do with the patient? Do you know?
Finally, the patient was operated to a new AVR.
Yeah.
No endocarditis.
Because I also, no endocarditis, right?
Uh-huh.
And he was symptomatic, obviously. Interestingly enough, one thing in the clinical situation that doesn't necessarily fit well, and you have to find another explanation, is why does he have edema? Right?
I don't know.
Edema, if it is heart failure related, the right-sided pressures have to be high.
Okay.
Right?
So I know he has some kidney disease, etc. Maybe filtration is less and all that, but I think we agree.
Would you consider an MR? Just
No need. Because it's not going to help you more, right? If there was a vegetation, you don't see it as well with MRI.
No, I was thinking regarding the prosthesis rehabilitation severity to make sure it is monitored.
He's a combined lesion. The stenosis is probably even more than they are. So it's a combined lesion.
So continue next clinical case. Clinical case number 3 is a 4-year-old female with bicuspid aortic valve in status post AVR in 2008 due to an infectious endocarditis, and status post redo AVR in 2014 due to prosthesis dysfunction, actually asymptomatic with a gestational desire. Her past medical history included the hypothyroidism, and the physical examination, the vitals were normal, and she has a mid-systolic murmur at right upper sternal border. Here we can see like a short timeline from the procedures of the patients, the first surgery in 2008 and the redo in 2014. For this moment, the surgical findings included severe stenosis of the aortic annulus with impossibility of remodeling and increase in the prosthesis size. So the first prosthesis was on perimount number 19, and the second prosthesis as well was a perimount 19. And finally, after 2015, in clinical follow-up, completely asymptomatic. So here we can see the TTE. These are the images, and in the box you can see the numerical values.
And is this when? The date of this?
The date is the last TTE is from 2022, basically the last month.
8 years after reading.
So these are the images of the aortic prosthesis and its Doppler evaluation. The measurements are displayed in the box. And now we can see the echo record of the patients. The oldest echo near to surgery date is from 2015. So here you can see the measurements in 2018, 2021, and 2022. However, for this year, we appreciated a major increase in velocities and gradients aided to morphological change of the valve. Here you can see again the reference values for the perimount 19. As you can see, is the basically was a chord in this year. So let me see. These are the reference values, and from 2015 were similar, 18, 21, and this is the images is from this TTE. So the first question for this case is, what is the mechanism from the velocity and gradients increase? ¿Cambia?
Tienes que sacar el láser. Ahí ya está. Ahí.
Okay.
Proyecta otra vez. Tienes que no utilices el láser. Entero.
Go back to that. To the answers and people who have responded.
Here you go. That's a nice curve. So, what is PPM and prosthesis? And stenosis?
Participation mismatch and prosthesis dysfunction.
Okay, I know there was something missing there. What's a double reversal mismatch?
We just made that up.
And somebody voted for it.
Maybe can explain us.
Basically, imagination.
Okay.
This case is a real case. His attending is Dr. Umaña, and is a very close patient to him, and she deeply wants to be pregnant. So that is the reason to present this case. She's in fertility treatment, and the thing that she most wants in her life is be pregnant. And it's completely asymptomatic. And you know what is the evolution of the studies and the...
Can we go back even one more, if you don't mind, before we start discussing? One more. Is there another way before? Yes.
So, in addition to your diagnosis, the question is, what do you do with the patient? You are going to, okay, get pregnant? No, don't worry. Or adopt a child? Or what?
So what do you guys think? Looks like that was the majority. Do you have a question for them?
So the first answer?
Sí.
Sí.
You want me to comment? I'm bothered by some of the numbers.
Here is the winner was prosthesis patient mismatch and prosthesis dysfunction.
Yes, I understand. And I probably would agree with this. I'm not sure about this. I'm not sure about this. This combination, you cannot say anything about it. You cannot even...
Nope.
You cannot even invoke prosthesis mismatch unless you have a baseline with high gradient normal valve. At this stage of the game, you cannot invoke that. So if you go back, if you don't mind, to your chart, let's talk a little bit about the chart, because...
So, for example, this is the newest echo to the procedural moment. The surgery was in 2014, and this is like the first. And here we can see a little increase in peak velocity and mean gradients. It's 3.4 and 28.
This is academic. It's academic, okay. Meaning that the valve was functioning well. If one thing you don't have here, which is important when you look at progression of patients, all right? There are two things that you would like to see. Peak velocity is important. We know these. Peak velocity is important. Mean gradient is important. I want to know what goes into this equation. So if I'm looking at reports, I look at stroke volume, I look at VTI in the LV outflow tract, and I look at VTI of the aortic stenosis. This is the basis for this measurement. And I don't see the basis for this measurement. You understand my point?
Yes.
Okay. And let me tell you why I bring it. Because some of the numbers don't make sense. Okay? So if I look at these numbers, the ones that really don't make sense is within the past 2 years.
Okay.
All right, I'm going to stop here, and I want you to think. I want you to think as opposed to being fed and getting everything by osmosis, right? Remember that term in medical school? Rather than being fed, why am I saying that there is something fishy about the numbers, and you have to demonstrate to me that this is indeed correct. Okay? So I want you to take a look at these two columns and tell me what goes through your mind if you're an interpreter, a clinician. I know maybe a first-year fellow are not going to be able to get this one, but I know I have attendings here of different levels, and I want to know from you, why am I raising a question about the numbers? All right. Now, I don't want anybody shy here. If you know, tell me.
Well, I'm going first, so
Good for you. I like that.
so that I can hide between all the other answers. Well, the one thing that calls my attention is that when we look at the first echoes, we see a velocity of 3.4 and a mean gradient of 28, with an effective orifice area of 1.2. Then again, when we go to the later echoes, we see rather different values for the gradients and the peak velocities. However, the effective orifice area doesn't change that much. So the question that I have is, how can those values be so different with pretty much the same effective orifice area?
And even trending upward. Even trending upward. Now, remember, as I said, each one of these valve areas that you get has an error, right? And the error could be about 0.1 or so, but here you have a series of echoes, right? So that I could use the same diameter I used in my previous one and just look under the hood, right? What are the components of this? What bothers me the most when I saw that is, I'm seeing the gradient go up from velocity, velocity from 3.2 to 3.7, it went up further. Okay, we got that. And along with it, which makes sense, is that the gradient, mean gradient, went up from 25 to 30 to 43. Got that? So, if I look at the line below, my goodness, they're like about the same, right? Particularly this one. This one went up, and I don't mind some errors, but if this went up, and yet the gradients increased significantly, the peak velocity increased significantly, how would you explain it?
But it's probably with the left ventricular outflow tract is wrong. Probably.
That could be, meaning I'm getting a larger diameter of the LV outflow tract. That's one way.
The velocity index is also the same. Maybe the TBI for the output tract is wrong also.
Exactly. Remember, DVI is a simplification of your effective orifice area, where you take the, right? So the other thing is, did really the output of this individual get worse? Is the cardiac output higher in this individual? If the cardiac output is just higher, right? If the cardiac output is just higher, these two will go up, and effective orifice area stays the same. And that's why I went back to say, I need, what is the construct behind these numbers, right? If you tell me that stroke volume went up significantly to keep the valve area the same, I want to go even further below and say, how did you calculate your stroke volume? If the VTI is the same and your diameter has grown by 2 millimeters, it's usually the opposite, right? It usually shrinks down as aortic stenosis get a little worse. Okay? So my concern is these are wrong. That's my first hypothesis. Okay? And these are real. Meaning that actually this valve is getting worse. And don't be fooled by the effective orifice area. So I doubt you have the numbers here, but I wanted you to think. I wanted you to think of what goes, right? It has to make sense. Because the 30 to 43 mean gradient, I can bet you that the VTI of the jet, if you understand what I'm talking about, VTI of the jet went up from almost 80 to 115, 120. And that stroke volume, I really doubt, went up so much. Okay? Okay. So,
what do you think of a double reverse mismatch?
I can't hear you.
What do you think of a double reverse mismatch?
Well, tell me about that. Double reverse. Is this like driving a car and going back and reverse? And go back. Go back a little bit, please. Did you see that valve? Did you see the valve?
Oh, sorry.
Maybe go back one more. Play. Whoever dreamt of patient prosthesis mismatch? Look at this valve. It's a bad valve, unfortunately, for this young woman. Right? After 8 years, that's what happens in a young person, and even actually an older person at times. But it lasted 8 years. I bet you this gradient increase was a significant increase from the baseline and from the a year before, and her progression is really significant. So this is, to me, and I think that effective orifice area is, I'm guessing, because your Doppler velocity index, which is the ratio of either the VTI or a poor man's, this guy, 1 meter divided by 4 point something, the DVI is close to 0.23. All right? Which tells me that the effective orifice area calculation is wrong. Got it? So this is severe aortic stenosis for this woman. And then I'm going to stop here because I know you have questions, so we're going to stop there.
So I will show with the next question is regarding gestational counseling. What is the next step? So that what we can do with this patient.
Si estos pacientes, así es problemático medir, porque el doctor está mencionando cómo pequeños cambios en la medición pues nos pueden alterar el informe. Estos pacientes que tienen fibrilación auricular, en el hipotético caso que lo tuviera, siempre me ha parecido problemático en el sentido de que en el mismo ciclo cardíaco uno no está midiendo el BTI del tracto de salida y el gradiente transvalvular. Por más que uno promedie los ciclos, pues realmente no lo estamos midiendo en el mismo ciclo, que sería lo ideal, pero pues es imposible. ¿Qué recomienda el doctor en esos escenarios de FA para tratar de minimizar el error, aparte de promediar?
Déjenme les respondo porque esa pregunta ya la respondió. Sí. Cuando ustedes tienen ese problema, es atrial fibrillation, and how you assess all the measurements, you already answered the questions, so I want to explain in Spanish. Cuando uno tiene un paciente con fibrilación auricular es un problema que es una pesadilla, porque Ah, ok, cuando usted tiene fibrilación auricular, que no, es una pesadilla, usted tiene diferentes flujos dependiendo del momento en el ciclo en donde usted esté tomando los valores. Y el error más grande que uno puede tener es cuando uno está tomando dos flujos que no son comparables. Entonces, o sobreestima la severidad o la subestima. Entonces, la respuesta que tuvo él ayer a una situación más o menos parecida fue que o toma siempre los flujos más altos, o sea, si él está en fibrilación auricular y tiene una integral y está la mayor, ¿sí? Toma por el Doppler continuo la integral mayor y con el pulsado también va mirando y ve el más grande de todos y únicamente juega con los flujos más altos, o espera a un ciclo cardíaco en donde haya una pausa, haya un mejor llenado ventricular y toma esa integral, pero tiene que tener el cuidado que es para los dos, ¿no? Es para el Doppler pulsado y para el Doppler continuo, porque de otra manera va a ser difícil. Lo que las guías inicialmente decían eran tomar promedios de 15, pero pues eso no lo hace, eso no lo hace nadie, ¿sí? Entonces esa es la respuesta. ¿Alguien más tiene una pregunta? Lo importante de esto, the important of this case is how tricky is the assessment and the measurements. How important is to relate all the results with the physiology at what you've seen. So you always have to have all the measurements and have to match. If it doesn't match, something is wrong. And you have to have time. You cannot do it, this kind of studies, in 5 minutes. Probably it's going to be wrong. You have to have time and think. If something is not matching, repeat again and think.
No, en español mejor. Creo que me pueden entender mejor en español. Entonces, considerando la variabilidad tan alta de la medición del tracto de salida, yo podría obtener una medida confiable en un primer eco, digamos 2015, y utilizar esa medida durante los siguientes años para hacer comparaciones o sea, tomando como la referencia desde un primer parámetro. Es algo que me he preguntado, como ¿qué tanto podría variable a una persona en el curso de 5 años ese valor? Sí.
Did you understand? Okay. I think the answer is yes, but let me translate. If you have like in this case, a serial of studies, and you can use the same LVOT diameter of the first study and use it in all the rest of the studies, no matter what you say. I think 2 millimeters was done 10 years ago, 8 years ago, and now I forget what I seen. I use the same 2.0.
In theory, you could, but you should not. And I'll tell you how I would do that. You have a series of studies, and the heart at times changes. Okay? The annulus of that valve is not going to change, but maybe conceivably what's under the valve may change. So, at times, maybe the first study, you estimated the diameter. And maybe the second study, whoever got, you have a larger diameter. So I would recommend that you would look at, you need to try to identify if your physiologic assessment is making sense before you start assuming a same diameter, okay?
if the VTIs and the LV outflow tract are about the same, and the VTI and the gradient through the valve is growing and growing and growing, forget about the diameter measurement. Most likely, this is a progression of aortic stenosis. If you see some peaks and valleys in the measurements, just like this one that doesn't make any sense, you have to take a look and see, what did they measure before? Do I agree with that? If I assume it's the same, what are they like? It was fine. So, you understand my point? And you can force it to be 2, particularly if they're closely related, meaning I'm not going to use the diameter of the year 2008 to use in my 2022. The last one you may use the same if it makes sense. So I would look at them, make sure, and always when you measure a diameter, you use the largest diameter, not an average. You know why? Because you're trying to get a cross-sectional area from a circular geometry. And if you underestimate the diameter, you're going to underestimate the cross-sectional area. And the only error that you could really do in addition to others is when you cut it you cut a circle, right? What's the error that you would do? Not going through the center, right? So all the errors will be underestimating, and that's why when you acquire these images, you want to make sure that you scan a little bit through it just to make sure that I get the largest diameter. So rather than forcing yourself always to use the same diameter, look at the totality of what you're trying to infer. Remember, the most reproducible, unless a heart attack occurs, ventricular dysfunction, something else, the most reproducible is the CW jet. If it is done compulsively from multiple windows and you get your measurement. So I look at that first. So, there's a change. Why? Did the heart get more vigorous? Fever, whatever it is. You look at all these components for you to come up with a decision. Stable, worse, cannot be better. Right?
Okay, here the winner is the gestational risk is high and getting pregnant is not recommended. So, our cardiovascular surgeon decided to exercise stress echo, and during the exercise the patient had an adequate chronotropic response, flat pressure response, and adequate exercise tolerance. The Doppler spectrum is from the peak of the exercise. Here you can see the values, and the patients did 12 MET. So, what would be your opinion about the patient's gestational desire? Finally. Any comments, questions, opinions? So the majority thinks that pregnancy is possible, however, the gestational risk is intermediate.
First of all, what do you think about the surgeons asking for an echo stress in this case?
And you can speak freely around here.
I think it's okay to get a stress test. I'm not sure I'm going to get an echo stress test per se, but you need to find, the gradient increase is not unusual. It just scares you more than her. What you're looking, I would look first at what this individual does in their real life. And if they have a lot of exertion that goes up and down on flights and so many other things, and they're completely asymptomatic, I don't think you need a stress test. If this individual is more sedentary, if you will, I would do a stress test. Mostly to see whether you induce symptom in somebody who's much more sedentary. Treadmill may be enough, actually. What are you going to look for? All right? If you're going to look for something, I'm not going to look at the gradient between us. If I'm going to look at something, I'm going to look at the ventricle, not the gradient.
It's a discussion that we have here with
Because, the gradient's going to go up. We're the ones where stress testing would be very important is patients, to me, is with Doppler as opposed to without Doppler, is in the mitral stenosis, where the patient is symptomatic, yet the baseline echocardiogram is not that impressive. You see what I mean? This is where you need. Here, what you see is not unusual. Output's going to go up. Ejection time is shorter because of tachycardia. Gradient's going to be astronomical, right? So that's the issue.
You should be worried if the gradient doesn't go up.
I'm not worried. I think physiologically it will go up. All right? You may not get the jet. You see what I mean? It'll be much more technical than anything else. So if you want my opinion about this patient, I think, this is a one-on-one talk with this individual. I know pregnancy is very important, and that may be the first thing. She's 40 years of age already, okay? And the question is, and between us, a normal stress test of 12 METs, okay? Normal stress test of 12 METs may not tell me anything at what she will do a year down the line. Right? Because she may have more progression of aortic stenosis. I'm talking about if, she may have assisted pregnancies with infertility and all this. That's what I'm sensing here. And if she goes through all this, which usually takes a couple of months for it to start, and then another 9 months, is what would her risk be 1 year, 1.5 years down the line with progression of aortic stenosis. And as you know, stenotic lesions don't do as well as regurgitant lesions with pregnancy, right? So if this patient goes into pulmonary edema, she's not going to make it. So my advice in those situations, I sat down with her, I said, listen, this is a situation, I know how important pregnancy is, but we want you to be around. Okay? And she may say, pregnancy is very important for me, but what are my options, doctor? And I would say to her, okay, is pregnancy, we have other options for you. Okay? Conceivably, we could do a valve-in-valve, outside indications. You could have another surgery. I want to make sure that you are surviving this pregnancy if it goes through. It will be earlier than what we would like, but maybe not too much earlier, right? I know she's asymptomatic now. How long do you think this individual is going to be asymptomatic? From what we know, within a year or two, definitely 3 years, most likely she'll be symptomatic. Unfortunately, they were not able to enlarge her, thing, and most likely also she wanted a biological valve because she wanted to be pregnant, so you're talking about another layer, and she hasn't been able to get pregnant with infertility issues maybe or something else. So she has to be, I mean, you have to have a conversation with the OBGYN person, and most importantly with her, because her risk may be intermediate at this stage, but may not be intermediate by the time she would deliver. That's my approach. I don't know how she was managed, Gabriel.
It's very recently, and I told Dr. Umaña that I'm going to present this case, and I will tell him. I will tell him.
I would welcome your approach. I mean, these are not written in the guidelines of neither management of ACC nor ASE nor anything else, and you have to kind of put your situation here because, again, there is progression of this underlying disease. It's going to progress while you're doing other things. So just imagine, you give a green light, okay? She goes through her OB/GYN and all this kind of thing, and then 6 months later, she gets pregnant. What happens a year and a half later? Do you think her risk is less or the same?
Another practical question, and is my concern, because here surgeons likes to screen the patients with stress studies. Yes, severe aortic stenosis. The patient is supposed to be completely asymptomatic, so they like it, and I think it's okay. But one of the issues that I have seen is the interpretation of the blood pressure response, because some years ago the response should be increased systolic blood pressure 10 millimeters, more than 10 millimeters, 20 millimeters, and now the Avatar study brings up, and they interpretation of the blood pressure is decrease of more than 20 millimeters. And this is completely different when where I was seeing, and in my brain, a person who is running and decreasing 20 millimeters is doing very bad in the study. Is not feeling good, so must have symptoms in that moment. So maybe the symptoms are more important than the blood pressure response. So actually, I don't know how to interpret the blood pressure response now.
To tell you the truth, I don't do much stress testing. I know it's written in the guidelines. I would do stress testing if I'm concerned that there may be symptoms. Most important thing to me is get a decent history and see how sedentary individuals are, right? Versus how active. If they're bicycle riders and they jog, whatever it is, and they're asymptomatic and all this stuff, I mean, what am I gonna get? So usually I look also from the echo point of view, not only at peak velocity and gradients and valve area. I look at the remodeling of the ventricle, how much hypertrophy, what's LGS like, what's the diastolic function like, is it starting to have high filling pressures, other things that are not written in the guidelines, what's BNP like, right? Because these are physiologic situations. The stress test is a one-point time. And then try to put it together. Also, you have to look at this, right? Then you have to look at the milieu of this patient. What are their comorbidities? What's their age, right? If I buy 1 year in somebody who is 76 years old, all right? They have severe aortic stenosis. We know what the progression, particularly if you have a series of advancement, you know what's going to happen. So you have a discussion with such patients. I'm not against stress testing, but most of the time, if you put all these together, you figure out where these individuals are. Blood pressure during stress can be quite variable. If you're waiting only for 20 millimeters, decrease, I mean, this is really horrible. And actually, some of these patients may not do well during treadmill. And these are the most difficult patients if they arrest. for you to do something about. So, right? Because you can't resuscitate them as well.
I'm sorry, I have one quick question, Dr. Now that you brought it up. How do you assess the functional capacity or the decline in functional capacity on a person who does sports regularly? Because I mean, it's not the same like quantifying the NIH classification on a person who does sports on a daily basis or on a competitive level.
You know their baseline. If they tell you, doctor, I used to run 5 miles, I'm now able to run maybe 2, and I start getting short of breath, that's symptomatic for that individual. And remember, sports in somebody who has severe stenosis, you have to be very careful. Because just imagine what this ventricle is going through during stress. You see the gradient there. This is the gradient, right? So this ventricle seeing 100 millimeters of mercury, not if somebody who has significant aortic stenosis, and have a discussion with them as to what are the pros and cons and things like this, and if they have a lot of remodeling and other things that are of concern, you might want to intervene before, because many of these driven athletes are really driven. You're not going to stop them. And you may want to aim for their safety maybe a year or 2 earlier, as opposed to let them plow asymptomatic at a peak velocity of about 4.3, 4.5 millimeters per second.
Bueno, thank you so much, Dr. Zoghbi. We're going to have a break. Okay, boys. In your life, you can lose a lot of things. Most of those things you can recover. You can lose money. You can lose sometimes your job. You can lose a friend. But you can recover. Maybe more than you have before, sometimes. But there is one thing that you have never recovered. Never. It's impossible. And that thing is time. You cannot recover time. Dr. Zoghbi, you gave us 3 days of your life. This is the biggest gift that somebody can give us. So deeply inside, I don't have words to say thank you. Thank you. You have been my teacher, 1 in 1,000. And you're a great teacher, and mostly you are a great person. So this is a little plaque. Somebody can help me, please. It's just a little plaque. I don't know where you are going to put it. But when you see it, remind us, because we never are going to forget you, never. And thanks a lot.
I know where to put it. I know where to put it. In my heart. Gabriel, time flies, and I agree with you. Dr. Salazar was with us for 1 year, 28 years ago. And our friendship, although we don't see each other often, It just, we can catch up within few hours like nothing has happened in between. And as I said before, I'm so proud of what you're able to instill here in this institution, which is training the new generation and expecting from your colleagues the best that they can offer towards their patients, towards the other colleagues in the institution, and the good of what our mission is about. Another advice that I usually do for myself is I take a little time to make sure that I am fulfilled in all my own mission. Work, look back, are you fulfilled? Are you pushing it to the utmost that you can? Do you need more training? Do you need to go to a meeting? How do you enrich your professional life? But this is not the only component, obviously. Your friendship, the friends that you have, your family, which is usually number one. People talk a lot about, work-life balance. But if you're in the right position of the things that you really like, you don't count the hours and you'll find the time. It's not a job. This is a mission. And for the young, graduates or young colleagues or young trainees, find your passion. Some people are born with it. They know exactly what they want. Others, they have to discover it on the way. Missteps are okay. There's nothing wrong with that. As long as you don't do missteps throughout your life and then you look back and say, okay, well, I haven't been able to achieve anything. But, our time at this time, and I know you too, is to make sure that the next generation has what it needs to carry on the mission. And I'm very proud of what you've accomplished. The people that I've met are very driven, intellectual, thoughtful, caring, and I'm very pleased and honored to be here with you. So I didn't have to think twice of extending my day because, in truth, I like this forum more than any other forum because, interactions, solving problems, addressing issues is much more interactive than, reading a guideline or reading another paper. And I think you have to be also critical of reading papers, and that's why we write editorials. And I want you to think about that, because some whatever is published is not all nice and clean and truthful. I'm not talking that this is malicious, I'm talking there are maybe errors in there that you have to be very cognizant of and talk about it. And that's all for what? For the betterment of this community, the population, health. And health is very fragile. Don't take it for granted. And enjoy every moment that you do. There's nothing wrong in working hard, actually. Me and my wife work very hard, but at the same time, we enjoy ourselves, we travel, we enjoy our kids, our grandkids. So it's not mutually exclusive. And I know you will find the time and the balance to be able to do that. So, number one, thank you for the honor. Great to be with you. My second time in Colombia, and it feels like home already. First time was in Cartagena a few years ago. And but this time I got to know Colombia because we have some colleagues back in the US who are from Colombia. Carlos Leon, as some people may know, he's a cardiologist in Miami area. Juan Carlos Plana, who is in Houston at Baylor St. Luke's. Juan Granada, and all these are previous fellows of mine. And we pride ourselves with our trainees because they are the next generation. And you have that mission. You're going to train people. They're going to look at you as mentors and facilitators of their life. And that's something I cherish very much. So thank you very much.
Entonces, la siguiente sesión es for you to have you the non-electric chair.
Do I have to test it?
Solamente dice, en gratitud al doctor William Zoghbi por una vida de contribuciones la leo en inglés porque for a lifetime of unparalleled contributions to the fields of cardiology and ecocardiography. Bogotá, Colombia, October 2022.
Thank you.
Y the next session is you guys asking him whatever you want from a master in the field of cardiology.
So sweet.
Have a seat.
And don't be shy, right? You can ask anything you want.
I'm going to break the ice because
Break the ice.
so how come a Lebanese AUP graduate ended up being the head of what was the pathway? What made you think, okay, I'm in Beirut and now I have to take off and have a different type of training?
None of it was planned. And that you will find out in your life that many things that you ultimately achieve and get there are not planned. There are very few things that you can plan. And keep that in mind because you're going to have amazing opportunities in front of you, and you'd better recognize when the opportunity is in front of you. And take, at times, I mean, it's a hard decision at times, but also at times it's a difficult decision because, and I'll share some of these with you, because opportunity, adverse and positive, has knocked on my doors, and the same thing will happen to you. I'm pretty sure each one of you has a story, and none of them are the same. None of them are the same. I grew up in Lebanon, beautiful Lebanon. Many people, pretty sure you've met quite a few Lebanese. There are more Lebanese outside Lebanon than in Lebanon because it's a small country, about 4 million plus. There are about 10 million plus outside Lebanon. Everywhere you go, you're going to find a Lebanese. You may not like that, but they're going to be there. I grew up and never thought I will get out of my hometown. It's a beautiful hometown overlooking the Mediterranean. Fishing, water skiing, snow skiing, everything else you can imagine. Actually, if I take some of my people there, said, what are you doing in Houston? But I was at the university and adversity knocked because in '75 the war started because of issues of Palestinians and Lebanese and got worse and worse, almost killed twice. And then we decided and said, we need to get out. And medical school in Nashville, Tennessee. And actually, if you look at it from a site of what is this medical school, it's Meharry Medical College. It's one of the black colleges in the United States. There are 3 of them in the United States. So if you talk about ranking of where this is, it's probably close to the lowest from a ranking point of view. But to tell you the truth, they were welcoming to me and my ultimate wife, who was a medical student with me. And they gave us the opportunity to be able to grow. You can take these adverse conditions and build on them. For us to be able to get to know, so we took electives almost everywhere. Matched in Galveston. I wanted to do cardiology throughout, so Houston was not too far. applied for cardio. After internship, I went there and loved it. And she did the same in pediatric neurology. She's a famous neurogeneticist. And Houston was our home. And we grew up there, and I had a mentor. That's for you. Better have a good mentor that would help you. And you have great people here to be able to shepherd you. And my mentor was Mike Quinones, who I know some of you met. He came here. I wanted to do cardiology throughout, and fell in love with Echo. And the Echo at that time, we're talking here in 1980, was a huge machine, just like a refrigerator, and it was an E4M machine, and I just loved it. And you know what I did is, in training, what I would do before I do an ultrasound, I take my stethoscope. That's how I sharpen my physical examination. Try to make a diagnosis, my physical exam, before I see the heart in front of me. And it was a great skill for me to help me out. And then, he introduced me to the college, to the ACC college. And we started, doing courses at the ACC, the old ACC in Bethesda. And networking is important, but networking is not enough. You have to do your homework. You have to do the work. If you're into research, and there's nothing wrong in being just a great clinical person, but if you have that desire for contribution, for innovation, you're curious, you want to answer questions, and if you think all the questions have been answered, you can forget it. Tons of them. And I was curious. And curiosity is very important in research. Towards perseverance, hard work is there. And that was a great platform for me to grow from. Research and ultrasound mostly. And then you get to be known because you publish more and you speak, and you get to be known, and you're tapped on to be able to do other things. American Society of Ecocardiography, I was its president in 2008. Before that, you have to do a lot of things. Committee things, volunteering, being altruistic, spend quite a bit of your time. You talk about time. What do I get from this? Right? I get to know you. I get to interact with you. You build friendships. And yes, this weekend I'm not spending it with my family, all right? But next weekend I will. And if you take away a little bit of that, the young generation want to be with their kids, I can tell you, in the United States. They want to do every little thing. I mean, if they take 3 steps, they want to be with the 3 steps. But you could balance it, and you could do many things for yourself. And many of the positions that I was able to do, ACC presidency and all that, that was not on my radar screen. Actually, to tell you the truth, I was not interested. They asked me to run for it. Some people are driven, they want a position somewhere. Not interested in that. And, but actually, but being president, actually, you could move the needle. CardioSmart, that was my legacy there, and if you go there, it's in Spanish and it's in English, and it's great for patients, for caregivers, and other things to get good knowledge. There's a lot of trash on the internet. And now I'm their chair of cardiology. Was all this on my radar screen? Very little, to tell you the truth. But I enjoy what I do. When I hire people, I hire them for their value, for their culture, for their personality, much more than their skill. You're going to find a lot of great skills. You want collegiality, you want interaction, you want a collaborative group, you want a common vision of what you want to do. And actually, you pride yourself if you don't have a lot of turnover in a department. You hire people and they leave after 2 years, and you hire another. You don't want to see too much of that. They usually go for bigger positions and other things. Dr. Estep was my fellow. It was great to see him, head of heart failure and then now head of cardiology in Cleveland, Florida. So that's what you want. That's what you want. So the reason I'm spending a little more time is it is my opportunity to share with you of some of the ups and downs, and I'll share with you some of the things that I felt very uncomfortable with. I was asked by the ACC to chair the scientific sessions. I did not know I was ready for that. My home is imaging and ultrasound. Now you have to chair a meeting for 20, and that was in the year 2000, for 20, 30,000 people from prevention to interventional, and you know how to interact with people, and you learn. I pondered on it about 2 or 3 days and said I could take that. And it's a different thing, and you widen your horizon, given opportunities. So you're going to be given a lot of opportunities, and at times some of them may give you palpitations. You don't have to have an EP doc close to you, but somebody's gonna ask you, and there's a lot of volunteering in this job. There's a lot of altruistic things. Look at these 2 gentlemen here. Preparing such a meeting, take care of every little detail, agendas, topics, and various things. And for the youngsters, if you look at people who are already achieved, it doesn't happen overnight. It's a big journey. It's a long journey. So don't be taken back and said, "Oh, I'm not achieving this." Be patient with yourself. As long as you're on a certain road, you have your 2 feet on the ground, you professionally develop, you go interact with people, go to meetings, travel, that's okay. I tell people, you need to get out of your home, your professional home, at least 3 or 4 days, maybe a week per year. Go to meetings, national meetings, be it here, be it in the States, be it in Europe, whichever way. It's worth it. You learn from other people. The most I learned in my professional life was being on the board of the ACC. You think you're smart? You're not that smart. And you learn from other people's behaviors. You learn from the way they think. They solve problems. Today we had an interaction on how do you solve problems, right? Each one is different. I'm pretty sure I added to your lens a little bit. And you can add a lens to other people. And my approach is probably a bit different from the other speakers that came. And that's okay. And that's most of the time what it is. But you learn from watching other people and emulating. Some people have a role model in this versus that, and I think that's how you're going to grow. Sorry for taking long, but I felt this is an important message. I'll share with you. I want this to be interactive. Any question that you have in mind, anything, and there's no dumb or simple question, really. And I think you have to be honest with yourself. Yes. He's the most vocal guy. Let me tell you, he's taking the limelight from you.
Actually, I have 2. One personal, and one on the fellow kind of specter. The first one is, since you have participated in so many guidelines, there's a saying that goes around here a lot, is that well, take a look at everybody eats the guideline because they're like sausage, but they don't know how they're made, so if they did, they wouldn't take them for granted. But I do believe that for people like us at our level of expertise, we do take a lot of support from the guidelines to make decisions. So how would you believe we should approach those recommendations, because I do believe they're important, especially those first class recommendation and the class 3 recommendations. And on the personal side, how do you think a fellow should approach his time, making a balance between the personal life and the academic life?
That's Blaise Caraballo's quote.
I'm sorry?
That's Blaise Caraballo's quote. Guidelines are like sausages. That's Blaise Caraballo.
They're not like sausages, to tell you the truth, because you know what's behind the guidelines. The sausage, you'll never know what's behind the sausage. Guidelines are what the name says. It is a guideline. It's overall a guide. You can't put every patient in this guideline, and you're going to have to use your own, thought about it. They usually converge into a common denominator that most of the time is helpful. But remember, these are living documents. So by the time a guideline is out, I wouldn't say completely outdated, but give it a couple of years, it needs a refresher, right? Because knowledge and data is coming out, and you have to incorporate it one way or another, and you see how solid the data is. At times it takes longer for the data to solidify, because there is a little conflict behind investigators as to pushing their own agenda and their own data and how good is it, and right, you got 2 trials on the mitral valve, right? One is negative, one is positive, and try to dissect what's good and what's so. I take the guidelines as a general approach, but you have to understand what goes behind it, and they're there. It's not a recipe, and the other recipe that is not there is the personal opinion of the people sitting down and getting a consensus. And it takes time. The time that it takes is because you don't have solid data to tell you yay, nay, right? There are a lot of things that, and at times the guidelines will push for newer data. And I'll share with you that when I wrote the guidelines on valve regurgitation, you see all these 3 or 4, where did this come from? Where did this come from? It comes from a lot of clinical experience, that these are important, but in truth, and I'll share with you, I had to test it myself in my own practice just to see whether it makes sense, yes or no. I gave it to our fellows to test it, and to some of the committees to see, does it make sense? Because it is not based on a conglomerate. To make these tables and recommendations took about 1.5 years. And every little detail is thought of. Now, is it perfect? No. I'm sorry to say, but Dr. Uretsky's, trying to, and it's not a defensive thing, right? So I would fault, personally, Dr. Scott Flem of not knowing what was behind the scene because he was not aware of that. So you have to be careful of, now we're not defending this, but we want the data to defend it, right? So a lot of things go behind the scene, but the data, and the data is going to evolve. Now, are we going to have another recommendation for valve regurgitation soon? I doubt it. It will be another probably 10 years. You're going to have a new one coming out for prosthetic valves, and that will be, I'm the chair. And I said to myself, this is the last time I'm going to chair the guideline, because I'm not kidding you. Every night, over the past 2 months, I'm working on it. And this is for the common good. You ask people to do a few things, and some of them respond, and who responds and who doesn't respond. And the people are on the committee at times are political appointees from various societies, and who's going to work and who does not going to work. And I want to make sure on the committee that I have vocal people at the same time, or contradicting people, so at least you bring them in the tent, as opposed to for them being outside the tent, and shooting darts at you. So, and I share with you, except for Dr. Uretsky, I have nothing against him. You know, I haven't met him even. But except for Dr. Uretsky, I have not received a single email from 2017 saying that there's something wrong in these guidelines. Not a single one. Now, you don't get praise either, but that's okay. Actually, you get praise, but not a single one. So I feel very comfortable with that. And there's a lot of introspection that goes in it. You know, every study that I do, that I ask my fellows or my colleagues to do, and actually, you know what we have actually. Last week, we had a meeting with fellows and faculty together, all together, talk about research. From ideas, what would you do at different levels? How do you write a paper objectively? What should be, I mean, the most important thing is a hypothesis. And how do you construct a study so that you think as a reviewer, as a critical person, so that ultimately when you come up with is applicable in the vast majority of situations and not, you know, being shot at wherever you go, right? Going back to your second question, how do you balance? Your professional life is demanding and your family life is demanding. Are they conflicting? They usually conflict on time. I do hope where is, at least, there are two areas where it could be a sensitive thing. One is that you have to have a supportive partner who understands what medicine is about and what is needed. It is not a 9-to-5 job. Hopefully, you date, married, fiancéed to somebody who understands you, and not necessarily that if the partner is a medical doctor that indeed at times it can get worse and at times it's understanding. So you have to balance that, figure this one out. Make sure that you spend quality time at home. We spend more time at work, irrespective, no matter how you calculated it, because there's a few hours for sleep, and there is, you know, evening and maybe a morning. You know, the evening is a little longer, so you have to figure it out. And to me, it depends. Each one of you is at a different stage. Some of you are married, some of them have kids, and whatever. Spending time, quality time, is the most important thing. If you're picking up your peripheral brain every 5 minutes, texting and bringing all the work at home every little time, is very disturbing, is very annoying. And at times you and your whoever is at home, you may have to have some kind of agreement. I do that with my wife at times. Said, "Oh, what up? Can we take a break?" Right? So, because it erodes you so much. It's different than when I was growing up. There was not even AOL. Then AOL came in with dial-up and toing and all these kind of things. Probably you don't know what that is. There was no iPhones. iPhones like 14 years ago, right? So you have a lot of things at your hand. The other two, social media. Make sure that you're not addicted to social media. I'm not saying it's a bad thing. I'm saying use it appropriately. I don't go to social media more than 15 minutes per day, period. That's early morning. I scan most everything. I'm on Twitter. less Facebook. I don't tweet about my food and what the Halloween party yesterday and all that stuff. This is all personal. I don't opine on things, start controversy unless it's meaningful. If it is about an important paper, if it is something that would move the needle or at least alert people. So be careful. I mean, you don't have much time. And spend the important things at home. Events, etc., and coordinate some of that. My wife is a basic researcher. She's very prolific. I work hard. We have dinner, we have fun, but in truth, I work every night since my fellowship days, 1 to 2 hours at night. Is this, at times I get tired, I say, oh, okay. But most of the time is because of something. It's helping the fellows finish their paper. It's, whatever it is, it's for your mission. And hopefully you're coordinated, you and whoever's at home, to be able to do such and decide on such. If it is too much, if your spouse or significant other doesn't have any work at all at home and you have some work, you may decide to make it less, to make it every other day, whatever it is, so that it is palatable. Your kids, you have to be with them. To me, the most important thing when my kids were young is to have dinner together. Breakfast was a little different ball game, but dinner was very important for us because we can talk. You teach your kids values and how do you, you find out what's happening during the day, solve problems, share emotions, up or down. Be with them when they go to bed, etc., that you would do. Hopefully this is not interfering with the things. Dissociate. Then after that, you want to watch a little TV, you want to do a little work. There's nothing wrong. Some of my fellows said, Dr. Z, I was told by that once I go home, I don't need to touch anything else. So you could do that. There's nothing wrong in doing that. Depends what you want. If I do that, whatever we talked about today would not be achievable. My day is busy at times my day is so busy with everything else, solving problems, etc., that I have to read my echoes at 8 o'clock at night. So, depends what you want. There's an old saying in Arabic, which is the one who aspires to be at the top have to be awake at night and work. So you each individually decide what is the motivator. And to tell you the truth, for me it's not the position. I really don't care about the position. It's about my contribution. What is my legacy? And most importantly, what is my trainees or my family? That's what I tell you. My agenda is not mine. I'm done with that. My agenda is I want to make sure that you're taken care of, that you have what you need for your professional development, because at some point in time, you're going to be mushes. So there are many things that, and weekends. A lot of things on the week. Take care of yourself. Exercise, have fun, go with the family, do other things. Does it mean an all or none phenomenon? No. I can tell you, I work on the weekend. I work on Saturdays, at times on Sundays. It's up to you. It's really up to you. But at times, actually, working and finishing what you need to do gets you at ease mentally, because your plate at times is so full, beyond arepas and others. Your plate is right. Your plate is so full that by taking one thing at a time, you start breathing. I'm telling you what I have shared. Now it depends. You know, as a fellow, your plate is not going to be very full. You feel it's full, but let me tell you, it's not yet full. So look at it introspectively. If there are issues within the family and things like this, pause, find out what you need to do. If things, I'm thinking out loud because I'm telling you, that's our life. If things can be bought to make things life for you easier, buy them. I'm talking about help at home for your spouse or whatever it is. It's irrespective. If you could alleviate your plate so you have fun time, more time with your spouse, your kids, whatever it is, just do it. Hope that helps.
Dr. Zoghbi, hearing you speak, and we realize you're such an accomplished person. You have contributed so much to cardiology and ecocardiography, but you have an amazing family from what you're hearing, and you're also a very accomplished spouse, and your family, and you are such a down-to-earth person. And it's very common that people, when they start accomplishing and they begin climbing up the ladder, they disconnect from reality and they end up completely isolated. And not just academically, not just personally, it's the whole person that completely disconnects. How do you do it? How do you keep down to earth? How do you have such a perspective, not just in life, not just about science and academics and research and clinical practice, but you keep in mind your family, everything?
I mean, these are personalities. I'm sorry, you're not going to change that. I mean, I'm born this way. That's my approach. I'm more with the proletariat than with the elites. I could be considered one of the elites, but I really don't care about it. I don't know. Some people take themselves too seriously. It gets to their head. And feel if you're very powerful, then your nose is, way up there. You don't want to look at, that doesn't mean much to me. Actually, the magnet is not attractive to me, to people such behaviors. So my advice is, obviously, it's you. But don't take yourself too seriously. If you accomplish something, fine. I mean, each one of us, if I have a research, an accomplishment, I get an award or something like this, I mean, it's fun. Share it with you, but don't let it get to your head. And said, the most humbling experience usually for people, if they're is for you to be among others who are as smart and maybe smarter than you are. Learn from them. And as I told you, I learned the most when I am in such an environment. Now, some of them feel that they're gods, some of them like assistant to gods, and others are, more down to earth. So, and also, you find your own environment, right? People are friends with other leaders, etc., the leaders that you don't aspire to. They're on the side, they'll do their thing. Personally, stay humble with all your achievements. Interact with people. And as you grow older and you feel more firm, give back. Some multi-millionaires and billionaires actually have done that, monetarily and otherwise. Some have not. And the question is, why have they not? Okay? Same thing is in medicine, same thing in any position that you do. I'll share with you that at this stage of my life, I'm not very old, but I'm not a youngster either. So at this stage of my life, when I see my kids and I see my grandkids, and they have great jobs, they're stable and everything else,
I like to contribute to other things as opposed to just give an inheritance to my kids. I have chairs and support, people that are not able to make it in medicine, support research, support other things because I feel comfortable. Now, you're not going to feel comfortable at this stage of the game. You're rising. You want to make sure that everything is solid, right? But at some point in time, you're going to get to a plateau from a comfortable point of view. I'm not talking about from everything else point of view, and contribute back to the society that has helped you going through. So we help people in Lebanon. We have people now in Lebanon is going through major things, and even in the States and everything else. And each one contribute. It doesn't have to be money-wise. Could be intellectual, could be thoughts, could be mentorship, could be so many things. And giving back is among the most joyful things that to your community, to your environment, to whatever it is, whatever makes the ticker tick. Other questions?
You have been director, chairman, whatever, and you have to manage your colleagues, your team. So my question is, what is the best way to have healthy relationships between your colleagues and a good environment to feel to the well-being and to grow up, and all the issues that matter in the relationship in your team?
This is a very important question, and it's not about leadership at the top only. There are many, and we started actually an ACC leadership forum about 8 years, 9 years ago, and me and Dr. DeMaria started that, and we still do it every year. We bring 40 people, emerging leaders from throughout the globe. They fly into the ACC, and we spend 2 days with them, talking about various issues, and this is about leadership, right? And leadership, number one, is not as to where you are in that position. If you're a chief fellow, you're a leader. If you're at home, not alone, but with a little family, you're a leader. If you're head of a lab, you're a leader. If you have a section, you're a leader. If you're head of a department, you're a leader of this institution, you name it. So it's everywhere. It's everywhere. And the question is, how do you deal with other people? It's about dealing with people, right? If you think about the word leadership, it has action in it. I'm leading somebody else. It's not about me. If it is about me sitting in a corner, got nothing. So the question is, what are some of the characteristics for you to interact with people and bring them along? Number one, you have to have a certain vision of where do you want to go. Like you're leading the Ecolab here. What's your vision of the Ecolab? If you're dealing imaging, what's your vision? You have to have a vision. If you don't have a vision, you're static. And many things are changing. Nothing is static in life. But so having a vision is important. So I have to have a vision for my department. At times we have a retreat, we have a get-together. Forget about clinical work, forget about research, where are we going? What are some of the issues? How do we solve them? How do we instill? So that's number one. You have to instill
hope any better time, better place, better whatever it is. At times, things are very bad. You can't overemphasize the bad. You have to find solutions. You have to work on the bad, hopefully correct it, but you have to bring people and say, hey, if we do this and this, we will be better off. Let's do it together. The third most important ingredient is trust. And trust meaning if I'm with a small group, they have to trust me. And if they don't trust me, I could speak all day and nothing will happen because they are suspicious of whatever it is that I'm planning or having a different agenda. So trust and transparency for me is very important. That's how I gain the trust and the collaboration of other people. I sit with them in the office one-on-one, in addition to a group, talk about various issues, and I will have their back if they are appropriate. I will fight for them, whatever is needed. So most of my fights actually are not with my faculty. They're in the support that gets the faculty what they need. And let me tell you, I mean, these are at times big fights. But I insulate them because this is my group. And I said, I'll take care of you as much as I can, and I will fight as much as I can. I may not be able to get everything, but at least I'm there for you. So they know that they can trust me. And whatever I say, my word is gold. If I make a mistake, I'll acknowledge it. And if I promise something, I usually want to make sure that I can deliver. And if I cannot deliver, I have to tell them why I could not deliver. So they know there is transparency and there is trust. Trust is the biggest thing. And if you lose it, it's pretty much done. Because to repair it takes forever. It takes forever. So, another characteristic, be the role model and demand from them what do you demand from yourself. I'm the first volunteer. If there is a need for something, and if I can do it, I'll be the first to volunteer, and I'll give you an example. I have not attended in the cardiac intensive care unit for 10 years. Okay? There's a new need for faculty to be in the cardiac intensive care unit, and I know there is a resistance for more faculty to be in the unit. I said to them, I'm going to demand it from you, but I'll tell you, I'm the first volunteer. So you disarm them by not protecting yourself. Same thing with, we got 2 people this past 2 weeks. I got sick, ill in the lab. The director of the lab sends an email, said, we want volunteer for these 15 slots. Unfortunately, at times, it's an email that goes to cyberspace. Maybe 1 volunteers. I'll say, I know when to hit and say, I'm volunteering for this and this slot. I want all of you to volunteer. This is part of our group. This is what we're about. The emails start coming. But I'm not demanding something from them, and I'm isolating myself, going and fishing. So to me, these are the ingredients of having, and the last one is have fun. I mean, this is not a job. Have fun. So, what do we have for fun? New fellows in July, they get together for a happy hour with all the other fellows. In October, actually last week, we had a picnic with the families and their kids. in a park, catered all that. Faculty, spouses, kids, have fun. Actually, it was great. I had a great time. You get to meet the little bambinos and bambinas and all that. And it's fun. Not all of them will show up, and that's okay. Now, that's the usual. We have for the holidays, we have a party, we have a graduate, whatever it is. All what I'm saying is have fun. Have small groups where they share things. In the Ecolab, you're going to have a forum where it's not always maybe about cases, maybe a meeting for, hey, how are we doing? Right? Can we do things better? Do we need more help? Do we need a better, whatever it is. Basically a sense of community and a sense of people contributing to the ultimate goal of whatever that goal is. And it could be at this micro and a macro, big macro. And you're going to have the vision. We talk at times about personalities that are, they look at the details as opposed to the big vision. In truth, I look at both. Because at times I have to wear my hat of the chair and deal with administration and where are we going and what do we need. And I have to delve with the details with individual faculty or divisions that they need help. As associate editor, I have to take a look at the research and take a look at every little things and come up with recommendations for people. So that's me. But other people, you've seen, I mean, there are different personalities called red personality. The red personality is the impulsive, big vision, don't care about anything here. And it's a mixture of people that you're going to deal with. Each one has a different contribution, but the beauty is that actually you don't want it completely homogeneous. You want people who are much more vocal. We have one of them right there. And that's important. And the people who are a little more shy, you need to get out of your shell at some point in time. Nobody knows exactly what's going on in your mRNA in there and your thought process. Unless you say it, express it in a nice fashion, nobody's going to be able to act on it. And your voice is important. It should be heard. Cannot be a silent, somewhere all the time. Can't do that. Not going to move the needle. And always do it not as a self-fulfilling thing, but do it for the common good. If you get benefit from it, that's fine, because other people are going to get benefit from it. But do it for the common good, and then you disarm people in a way if things are better for all. So that's my approach. Each one may have a little different approach. Yes?
¿En qué momento de su fellow de cardiología tomó la decisión de que imágenes cardiovasculares era como el camino?
You're going to have to help me out here.
Yeah, so what time of it during your cardiology fellowship you decided you want to go into imaging? You were a first-year fellow, second-year fellow that you said?
Oh, when did I decide to go? Most likely it was during my second, third year. Is when I was exposed to the ultrasound itself. Now my mother tells me, may she rest in peace, that, and actually I remember that, when I was 5 years old, probably similar to Colombia here, when the mothers get things at home, the chicken and all that, and I would come, said, Mom, can I take a look at the heart? So she would dissect it for me. So that's a tomographic imaging. And I remember that vividly. Actually, she made sure she told me about that when I was a cardiologist. But I was telling other people I was going actually in engineering when I finished high school. And because I love math, I love physics and all the other things.
And I met engineers, and then I met physicians who were ahead of me, maybe about 3 or 4 years, and it was at a casual get-together, and we didn't have, mentors and whatever it is, people, advisors. We didn't have any of that stuff. And he said, "Oh, William, you would love medicine. I think it's just, it's the science and the humanities and everything, and I'm loving it. I think you should try." And I thought about it, and changed from engineering to biology and pre-med, and I love it. I don't change a thing. Yes. Yes. Yeah, please.
Thank you, doctor. First of all, I would like to thank you for being here. It's a really great opportunity to meet you. And when I have the opportunity to meet someone like you, immediately I understand why you are in the position that you are, because it's not just like the hard working, it's the constancy and actually being a good person and the leadership that you told us before. But I think that maybe the society and us, I include myself, maybe we are used to just see the tip of the iceberg, the success of people, the television, the skillful athlete, the skillful musician, the president. But I think that there is a pathway that it's a hard pathway, because you have to do a lot of sacrifice. Maybe you lost a lot of moments. You have to leave people, your country. Yes, a lot of things. But I think that people is not ready to talk about all those things that you have to do, and the feelings, and maybe every day you have to look for the delight of being alive, of being here in the institution doing your job. But maybe I know for sure that you had hard days, days that maybe you told yourself, I don't want to maybe go to the hospital. But it's something that everybody feels that, but people is not ready to talk about that, and people is not ready to talk about the hard, that maybe the pathway is. How did you find the everyday motivation to do all these things and to keep your head straight to the top of the mountain?
This is very important, really. Each one of us has up moments and down moments. And the down moments could be many things, to tell you the truth. Could be an issue of health in the family, yourself. Could be any struggle at work. Could be in research, somebody scoops you to something, or you address something and you fail. I mean, that's part of life. And you have to know how to kind of pick yourself up, surround yourself with supportive people who can cheer you on. At times it's hard to do it on your own. At times you have to take a little off. And just like each one of you, at times I feel burned out. Burned out, it just at times the plate is incredibly full. And you're not able to meet many deadlines. I can tell you, for JACC imaging, for example, I have like 6-7 papers and 300 things to do while I'm here, right? So they come in different flavors. Some of them are really bitter, and some of them are sweet and sour. But the most important thing to me is the environment of where you are. If you're in a good environment, you'll pick yourself up and you can go back. If the environment is bringing you down, then it's a different issue. I'm talking about
colleagues that I don't trust, that I just don't like how medicine is practiced here or whatever it is. And practice could be much more business-like versus that, and this is against my principles. There are different flavors. But if it is a continuous issue that you can't resolve, and it's resolved by either making a decision of getting out or joining something else, I would do it in a beat, in a heartbeat. If it is episodic, and each one are a little different, the good thing is that time heals. And in general, if you're a little more optimistic person by inner force, I am more optimistic person by inner force, as opposed to your inner force is flat or down. This is harder for you, because you have to figure out how to pick it up. And how do you pick it up? Back to the good bubbly thing towards your mission. Treat yourself well, because usually when you are in a difficult situation, the first thing that hits is self-esteem and think about yourself as opposed to anything else. So that's what I do. I do something that pleases me, that gets me back to baseline. What do I enjoy? I love music. Yesterday I was in my element, not necessarily, but the music was just beautiful. Just like I'm a lover of music, and I have Spotify. I always work on music of different genre, from contemporary to classic to opera, Arabic, French, you name it. So that's my go-to. The other is nature. That's for my go-to. I love gardening. So my garden is my friend, is my psychiatrist at the same time. So I take care of that. And family, and just going out and exercise. Exercise is a great reliever. You need to know that. Exercise is a great reliever of tension. So these are the things that I go to, and try to solve the problem, whatever that problem is. Tell you the truth, I have a problem now for this past week. I can't tell you what it is, but it has related to work. How do you navigate issues between your faculty and your administration and try to find solutions? At times, of the past 3 or 4 days, I haven't had great night's sleep, trying to figure out a solution. And I have a call this afternoon, and probably tomorrow when I get to Houston, and I have to manage it one way or another. And once you manage it, then you take a deep breath. You're not hypoxic anymore. And you go on. Then you maybe another little blip that you have to address. And I think, but that's life. No matter where you are, no matter what you do, remember, you're dealing with people. And it's not as black and white and all of them are the same. That's why you have to understand personalities and how do you manage different personalities. At times people are much more sensitive than others. As long as you stay somewhat optimistic, the glass is half full as opposed to half empty. Because if you're very down and you stay down, it's very hard. You won't be able to achieve, because some of these issues are not in your own control. But I think your reflection is right on, and each people will solve it maybe a little differently, but you gotta solve it. And at times there may be issues at home or other things, but be as reflective and as introspective or critical, so you can take other people's position and try to figure out a way to do it. People would look at you as having wisdom and comfort in trying to solve issues that they may not be there. Hopefully that helps. Any other questions?
No, I have
Well, thank you for the session so much. Okay, and while he connects, very just short and brief, what books have changed your life? I have one that I gave to this guy as a present because he's finishing his fellowship here. But what books really changed the way you act or talk, or you have a top 2 or top 3?
I mean, in truth, to tell you the truth, there are a lot of books on leadership and other things, etc. I don't subscribe to books too many times. So I'm less of a reader, interestingly enough, than others. But there is a book called The 4 Reflections that you may be interested in. I don't read books on leadership and other problem solving, etc. Actually, I like more action, mystery, things like this to divert me from from other things. I don't like horror stuff.
And you can keep the mic.
Okay, let's go continue with another clinical case. This is a 24 years old male with 4 weeks of chest pain, weakness, and dyspnea on exercise. Vitals were normal and mid-systolic murmur at the right upper sternal boulder. For the study, this is the TTE. Here we can see the images of left ventricle. The quantitative values are depicted in the box. So there are some images from the aortic valve with and without Doppler color. And here we can see some additional images from the aortic valve. And finally, Doppler evaluation recorded with increased gradients and velocities across the aortic valve. Here we can say for us it's very important to explore conventional and unconventional views with the PDOF probe, looking for highest velocities and gradients, and the values are recorded in the table. So the question is, what is the best next step? Okay, so it looks the winner is TEE.
We are TE fans, Dr. Soto.
I'm concerned about the silent minority or majority. You gotta voice your voice.
So let's look the TEE. So we decided to perform a TEE.
May I ask before you?
Some
questions? I mean, always, right? When you ask for another test, is always a reason to help in the differential diagnosis of what the situation is. That's one. Two, the advantages versus disadvantages if you have other modalities, right? When I trained, we had no TEE, we had no MRI, we had no CT. So our choices then was a transthoracic echo and a heart catheterization. That was a simpler life. At this stage of the game, you have many more choices, and you have to decide for yourself what is the best choice for that patient.
So,
I mean, I'm letting you think, because that's how you're going to address an issue, right?
so for this case is our main question was the aortic valve. We think it was abnormal. However, we can appreciate like a bicuspid morphology, but the opening seems seems well, or seems enough opening. However, what is the reason for the high gradients and velocities in a apparently good movement of the aortic valve? Indeed, it's a bicuspid probably, but we can explain the reason, or we can explore additional reasons for the high gradients and velocities.
Go back to the first, even before this. Before this. Okay, play. What do you see?
So we see an eccentric close and opening of the aortic valve is
It's a prolapse, doming of the aortic valve. Now, in one beat, maybe one beat, you see the restriction of the motion of the aortic valve in systole. So, if I'm the sonographer, I want to make sure that I can see. Once I'm surprised with the CW, I go back to the parasternal long and make sure that I can see the opening of this aortic valve, because this aortic valve is not calcified. This is a young individual with a bicuspid valve. You can't make the diagnosis of a bicuspid valve in a parasternal long because at times you're off angle, but certainly this is very suggestive. And on one of these beats, I'll tell you when. Now, one of these beats, you see the doming, right, of the aortic valve itself.
Can I ask you something?
Yes.
How many beats do you acquire at Methodist?
2 to 3, something like this. But that's in a clip, right?
Right.
So nobody tells us that I get only one clip. I may get another parasternal long clip, and most likely one with a frozen frame to measure the alveolar flow tract, right? So memory is cheap as opposed to 10 years ago, 15 years ago, where it was you had to figure out, how often, right? So this is, until proven otherwise, a bicuspid valve. Go next. Same kind of seeing, but I'm not seeing yet where the restriction of the valve is. This is systolic flow. Next. All right. This I can't tell much. This one actually I see ovoid flow, that you could see it there. But I'm pretty sure, let me tell you, pretty sure you could see that most likely the right and the left are fused, and it's a bicuspid valve. Now, you could say to yourself, oh, I want a TE because I'm seeing a CW that is so high, yet when I see the opening of this valve, it looks fine. Where is the stenosis? Remember, we talked about it before in the biological valve. The stenosis is much higher. Much higher. You're not going to see, most likely, remember there's descent of the base. You're not going to see this unless you're close to the tip. And it's doming. Actually, your best view of restriction, the best view of restriction is the parasternal long. Why? Because I'm not dependent on the short axis of where I get it. Remember that most of the time you're going to overestimate if you draw it or if you take a look at it, because you're not at the tip of where the abnormality is.
Okay.
Yes, the differential diagnosis in a young individual is, do I have a subaortic membrane or is this a bicuspid valve, or is it supravalvular stenosis? And if any of these issues, I may get something else. But if it's like a duck, and it quacks like a duck, and everything else, it's a duck.
So we decided to do the TE, and this is the most representative images of the TE. And here, at this moment, we will think about probably an unicuspid unicommissural aortic valve. I don't know any comments about this position.
I'm not sure about the unicuspid, really, to tell you the truth, because usual definition of unicuspid, right, is up to here, right? But on one of your views, you see the commissure is going all the way down to here.
Okay.
And you have to sweep, right? Heart is descending, valvular, so you have to sweep and maybe record more than 2 beats. You play around on your TE, 6 or 7, come back, right? So at least you see the whole sweep in there and find your best.
But when you're sweeping in and out with a probe, or you're sweeping in and out with a big wheel or small wheel? What's your sweeping approach? When you're saying you sweep in the medial esophageal right there at 60 degrees, you sweep with a probe, or you sweep with a big wheel?
Oh, it's with the probe. It's with the probe, and when you do short axis like this on a TEE, you have 2 options of sweeping because of the angulation of the esophagus to the aorta. Okay? One sweep would be, I pull the probe back and forth and record a little longer, so I'm at the bottom and towards the tip so I can see it well. The other one is clockwise, counterclockwise rotation, because if you do that, you're going to go through the plane of the valve. So you have 2 options. And the only reason you have 2 options is because of the angulation of the esophagus versus the aortic valve. So either you pull back and forth, or sweep through it like this. Then because you could see, not every beat is the same.
Sorry, doesn't the 3D images resolve the problem? I'm not talking exactly in this case, but when you have a good 3D, you don't have to sweep.
Well, if you want me to criticize this 3D, there's a lot of dropout. A lot.
Okay, but if you have a good one, you don't have to sweep.
True. The problem with 3D of an aortic valve is you're imaging from the side, and you have a lot of dropout, as opposed to imaging the mitral valve where you're en face, and the ultrasound is in the axial resolution. And that's why you have a lot of dropout. You know, you try to increase the gain and decrease the gain and, minimize, maximize, the dropout. But in theory, you're right. I mean, that's what 3D is about. It tells me the whole story from a structural point of view.
So finally, we did a 3D AB reconstruction, and a measure of the aortic valve was done. We tried to reconstruct it on the tips of the cusp, and the geometric aortic valve area was 2.6. However,
I'm going to scratch my throat here. Do you believe it? Do you really believe this is a 2.6 valve?
Well, that it was the best of the all images, and we tried to take it on the tips.
It's not at the tip. You know it's not at the tip. You know it's not at the tip. Another possibility for you, if you want to, play around, I would use biplane imaging, orthogonal plane. I would do one like this, and then you see the problem here already is you're at this level. So if I'm going to go a short axis, it's going to be a little problematic. They're not going to be all in the same plane. So what I would do is I would do a combination of this guy and take your sweep of your plane to be close to the tip. Unfortunately, as I said before, it's very tough to get an accurate measurement. You're going to overestimate most of the time.
Okay.
So once we have things like this, I was in New York, and Mitchler and Garcia were fighting about this, right?
I don't need to fight.
Garcia said it's a windsock, and because it's a windsock, it's so tricky.
Yes,
area.
very true.
So it's like a windsock. You know,
And he's right.
Yeah. Well, I'll tell you later what.
No, he's right. I mean, you know what's going to happen. If you're not at the tip, you're in the funnel. And if you're in the funnel, as this valve is doming like this,
Yes, it's like a...
you're down in the funnel.
Okay. So we try. Okay, for the moment, that was the question, the discordance between geometric and effective. This effective was estimated by continuity equation from the TTE. But so the question is the increased gradient and velocity are due to, please.
We have 2 votes. I really don't care. I like that one. Are these all the adult voters here? That's it?
So with the majority say it's a bicuspid aortic valve with severe stenosis. So
Do you guys agree on the majority? I think I have a question for this group. This one should not be in this room. What are you looking for, right? I mean, if I need more data, what data do I need? Can you? I mean, I want you to talk. All right, I'm not here to talk alone. Whoever said among the 4 or the 5, I'm not shooting. I don't have any guns. I don't have any ropes. You know, whoever wants more data, why do you want more data? Anybody? Yes, Marietta.
I would like to know how much is the aortic diameter?
The aortic, meaning LV outflow tract, or the aorta?
Aorta diameter. I would like to know how much it is. Because we are in a bicuspid valve, and it is small. We could think the patient will have that values over sobreestimados.
Yes, I got it.
So is the
and you are right on. And you know why you're right on? Because if you take a look at the previous image from the transesophageal, if you go back a little bit.
The jet is very exciting.
No, forget about the jet.
Okay.
Forget about the jet. I have no idea what it looks like here.
well, 42 millimeters. The what?
I don't see it. I have a minimum of 42.
Okay.
I do not see this black.
Okay.
John, I have no idea what the extent, unless the operator said, I have an aorta problem,
I adjust my angulation, I pull back to a point where there is shadowing from the trachea, then I can't see the aorta anymore. Or I do a transthoracic, forget about the valve, I want the aorta, I'm going to look back all the way in long axis, short axis, just to make sure. But I agree with Marietta that, what? I don't see the aorta.
So
and remember, this individual has chest pain. Is the chest pain related to this valve and the gradient, or is there something else at age 20 plus? Is there a possibility of a dissection? What's the aorta like? You're going to have to think about this gentleman for a longer period of time.
The proximal aorta was dilated, so the arc and the descendant was normal, and there were we can see an coarctation. It was not present.
How do you know that? How do you know this?
Because the another images and the velocity flows. So the images are not there, but we usually explore that too.
Okay. So go back to your questions.
So
for the response.
The response.
So is 8 correct? I mean, is BAV with severe stenosis, is that correct?
So we want to make a question because we really think that the aortic geometric area was well. So we try to explain that phenomenon. So we planted an alternative positive. It was a reversal mismatch. That was our interpretation due to the jet eccentricity.
Can I ask you a question? Dr. Zoghbi, would you send this patient to surgery right away? He's having chest wells after doing
I want to know. Yes, I mean I want to know what is chest pain like. I want to take a look at the aorta, make sure there's no dissection. And here maybe a gated CT I think would be a good one as opposed to other things because they have higher resolution, but it's got to be gated with EKG just to make sure, and you get a baseline, at least aorta size, etc., etc. I would be less in favor of doing an MRI, although it may give you the same diagnosis because I already know this is severe aortic stenosis. And the question is, are the symptoms related to the severity of the aortic stenosis? And maybe yes.
So between a bicuspid and a non-bicuspid, because the first case asked you to get a CT and you said no, in a 47 you were. So
yes.
In a bicuspid, obviously for sure, but in a tricuspid,
because I'm looking also for dissection, localized dissection.
Or core.
Yes, I mean coart, I will know it from the other one, but because of the higher spatial resolution, at times the dissection could be very localized and not your usual flap, right? You want a higher resolution test.
But the issue is that we want to know is some phenomenal, some physical phenomenon that maybe one is going to explain us is real, because we have read some papers and we have seen some lectures from Dr. Abbas, and he talked about the mismatch reversal, where the gradients are higher than the area, not the usual mismatch when you have low gradients and very tight valve. In that case, he says you can have some situations when the area is longer compared to the gradients across that hole. And we want to know if that is real, if that has a clinical impact, or is just a theoretical situation, I don't know.
I think, I mean, the gradient is real here. At times, you may have an overestimation of the gradient
in a small aorta. Or if you have a series of, stenoses, if you will, but this condition here is conducive to true measurement of a gradient. Now the flow is not excessively high. I know there was one question there, whether the velocity in V1 is higher than it should be. It looked physiologic to me. It's not that excessive. But I think this is really severe aortic stenosis bicuspid valve. And the aorta is not small. Where you have an overestimation of gradient is if the aorta is like 3 centimeters or below.
So we're trying to explain this phenomenon from the reversal mismatch theory, and we were thinking that in the aortic stenosis with the central forward jet, the velocity increase as the blood approach to the narrowest point. So at this point the speed is highest and the pressure is lowest. So opening theory in the aortic root, small symmetrical lateral vortexes form, and there part of the kinetic energy is converted into heat and dispersed. The remaining kinetic energy is converted back to pressure as the jet expands within the aorta, like this one similar. So that is the reason for the gradient between aortic root and left ventricle. So we were thinking about the eccentricity of the forward jet. For eccentricity forward jet, a lot of turbulence is generated, causing a high kinetic energy loss. Additionally, asymmetrical lateral vortexes are formed, which affect the jet re-expansion. All this causes a poor pressure recovery, and the gradients between left ventricle and aortic root will be highest. So we was thinking about that. In the second images, due to the eccentricity jet, a lot of energy is lost in heat. That is the reason for the highest gradients between aortic root and left ventricle, because the pressure recovery is basically is like the reason that we was planting, and for that
do you think that is a theoretical issue?
The eccentricity.
I don't know about. We've seen discrepancy between Doppler gradient and catheter gradients. What you're invoking here is pressure recovery, of how much of that phenomenon is seen clinically, usually in small patients, usually in small aortas, and usually in mechanical valves. That's what you see them. I don't know, but I may be not up to date, that eccentric jets in the aorta would do the same phenomenon as a small aorta. The only way really to, if this is in the back of your mind, as to whether there is an overestimation of pressure gradient by Doppler, you have to do a hard catheterization to see what the pressure gradient is between ventricle and aorta. That's the only way, because MRI will be in the same situation. Oh, meaning what to do with this individual?
So this was like a graphical to trying to explain this difference.
I understand that. Basically, the phenomenon is pressure recovery, right?
Yes,
and people have written about that, and where it happens in a native valve is in younger and older individuals where the aorta is small. And that's to my knowledge, meaning that the aorta, there is a formula for that as to what the size of the aorta is, but to me here, the aorta, I'm not talking about the ascending aorta, I'm talking about the aortic root and proximal to the valve, looks decent.
So because one of the theories is that inclusive in whole patient, there is some grade of pressure recovery, because exactly, so every of us have some grade of pressure recovery. So the grade of this recovery is that make the difference. A lot of pressure recovery or less pressure recovery, and that is one of the reason, because the theory says that
I understand all that. Number one, I don't like the name. Reverse mismatch. It's just like I'm more confused about it than anything else. It is really what you're looking at is an exaggerated pressure recovery, and people know what that is. And the only way truly to figure this one out, if you're concerned about it, is to go to heart catheterization. I don't know what you did, but
so the patient is in clinical follow-up. The cardiovascular surgeon decided to take a moment, wait, and evaluate the symptoms, treadmill test, and maybe, I don't know, if probably a catheterism, I don't know. So in this moment, the patient is on clinical follow-up only.
I would do a CT scan. I mean, you need a baseline aorta just to take a look at it.
Just a coronary CT scan that was ordered, that was normal, but we don't have a whole aorta, because that's what the surgeon asked for. So he needs the whole aorta on that side, because...
And you could do it at the same time. You see what I mean?
It was specifically requested for the coronary CT.
At a 20-year-old man, you know, it's just like...
Yeah, but it's a diastolic frame exercise.
What I would do personally, I mean, if you was at Methodist, I would do a CT scan that is gated, because we always do them at gated, so you don't have the motion artifact in somebody who has a lot of elasticity of the aorta, right? I mean, this is a young individual, so there's a lot of motion of the aorta. And I would do, you know, you will get your coronaries for free almost at the same time if you're going to do them together, and then you'll ask that question, and you have to go back with the patient and said, what is this chest pain about? Is this a one-time episode, costochondritis, or is this related to exertion every time I don't know what the situation is. Does he exercise? He's 20-year-old. What the situation is.
But it's a good example of high grading, high peak velocity, blah, blah, and then an area that can be deceiving in terms of you're measuring a little bit too low and then getting to the real tip.
My advice: don't measure area. You're not going to get it right. Not the way you're measuring it. You're not going to get it right. You're going to overestimate it most of the time. So rely, I mean, you have a beautiful study. You really have a beautiful study of the hemodynamics, everything else. If you want another assessment, and you would get actually the same area by doing the CT scan, you'll get everything here. And then you could play around with the plane of if you want to measure that, but the error usually is you go to the funnel as opposed to the tip.
And if we make the measure on CT, for example, our geometric area on CT, and the value is, I don't know, 2.5 or 2.6, for example, with CT in this patient.
I doubt it. I can bet you. I can take you to Vegas, and I doubt it.
The thing with doing that is that you assisted diastolic position, and even with 70, kV, it's going to be a high radiation scan. In that way, now that you're bringing out doing MRIs and class music, then you might want to swipe using MR. And you can do both. You can get a very good look at the other side.
But remember, though, you're not going to use a CT scan to follow up this guy. I'm not going to use a CT to follow this individual. My reason for CT is a high resolution gated to look at the aorta, not only size, but also structural. And you could take a look at the corners, you could take the whole thing. That's the beauty of a CT in this situation. right? Somebody with chest pain.
The thing is, if you want to measure the area, it's going to take a way higher radiation. So if the other option is doing a low kV, full aorta, high characterization of the aorta, and then doing a smaller box cell with systolic frame. You can do that as well. I mean, you can play as much as you want, but
Yes, okay, that's, we're gonna go ahead and start clinical case number 6. It's a 60-year-old female patient. Her clinical context is worsening in functional class in the last 4 weeks, associated with lower extremity edema. Her past medical history included hypertension, paroxysmal atrial fibrillation, and hypothyroidism. Her vital signs were unremarkable. She had an irregular rate and rhythm and had a pansystolic murmur at the apex and a grade 2 lower extremity edema. TTE images were acquired. These are the first images and measurements. And now for our 14th question. What is the severity of the TR? The platform is now ready for you to vote, please. We don't have any more votes. So I think all the audience concluded that the TR severity was the...
You didn't give them much option. you gave them severe and above. So you were influencing them one way or another,
bias,
right?
Yeah. Yeah, I was biased from the start. But now for next question, question 15. What's the etiology of this TR? The platform once again is ready for your votes.
You may want to give them more images again, since this is differential. Okay. What is the structure, right?
Okay. Yes, we can go back to the images.
Yes.
So these are the right chamber projections with the associated PV and CV. So now back to our question. Just remember, you're free to vote any answer. Well, this patient had a torrential TR, and she was put on, she was going to get surgery. The surgeons requested this MR, cardiac MR, as a part of right ventricular function evaluation and TR evaluation. So what we see here are cine images of the emphasizing right ventricular chambers, in which we see a normal function with a dilated right ventricular chamber. And what strikes our attention the most at this point is the severe LA enlargement with an LGE around the walls of the LA.
So it's really biatrial enlargement with transmural LG on both atrium. What's kind of the most striking finding? That's where Joaquin is showing. In the setting of a relatively small LV and with an already big LV, it's 117 is right. But both atriums are humongous. Severe biatrial enlargement. Not only right, but left.
Sorry. So she underwent surgery, had a tricuspid valve replacement with a Hank of 33 millimeter and a MACE procedure due to the atrial fibrillation. Following this event, she had an AF recurrence with hypotension, so a new TTE was ordered. In this slide, we see the pre-op TTE and the images at the post-op POP day number 5 with some measurements. These are right ventricular chambers. Well, left. And these are left ventricular chambers. She persisted with hypotension and an AFib rhythm. So this is our next question. What is your interpretation of the previous images? The platform is now ready for your votes. Six votes.
There's equalization of pressures.
So, Dr. Zoghbi, I don't know, but at the surgical description, surgeons didn't do anything to the mitral valve. What would be your comments about this? She had a TR, now the TR is fixed, but now we present ourselves with a worsening mitral regurgitation.
I'm really not sure about this case. One thing I know is what happened. You see the right ventricle. The right ventricle is severely dysfunctional at this stage of the game. Yeah, I mean, it was dilated to start with, but I mean, there's. So let's kind of review these. This is. Take a look at this ventricle. Take a look at the free wall. Don't worry about this guy, because this has interventricular dependence and it may move in different directions. I don't have as much. I'll tell you what I need to make a decision as to. Let's take a look at the MR also. You were concerned about that. Where's your MR?
Here's the MR.
Post-op. I doubt the MR is the cause here, but where's your MR? Now, I'm not talking about CMR. I'm talking the mitral regurgitation.
Sure. Oh, sorry. Lost in translation.
I mean, the MR is very academic, I would say. It's not even, I'm not concerned at all about it. Now you have a bit of a restrictive pattern, but this patient's in atrial fibrillation, so you can't tell too much about it. Aortic regurg is mild also. I really think it's an output issue. You know, what I would like to see for somebody with hypotension is I want to see what the LV outflow VTI is like. Meaning, is the hypotension cardiogenic or is the hypotension
hypovolemic?
Right. So if I have a decent stroke volume coming out, I want to know what the systemic output is. Right? So I want to know what pulse Doppler is in the LV outflow tract with its variability. I know there's a fib.
This is the pre-op.
Yes, this is pre-op.
Yeah, can we go to the post, because this is your issue is hypotension in an individual after valve, surgery. Okay, you could stop there. I really doubt this MR is significant. And the reason for it is flow convergence is not impressive. Now, you may want to do parasternal long and all these other things. Don't get concerned about the jet. You see, meaning pressure maybe in the atrium, which was hard. It could be more than mild, but I want to know more. If you're concerned about, so that's why a pulse Doppler in the LV outflow tract will tell me what is the systemic output like. I relate it to this ventricle. You may not calculate the regurgitative fraction or say, but I want to know, is the inflow here quite impressive? One thing that is bothersome is this is much more intense, early peaking, which means that the V wave, the regurgitant wave, is more impressive, meaning left atrial pressure is high. So I want to know more about this. So it could be more than what I'm seeing, but I have one single frame.
Yes. So we have these images here, right here, a TEE that was done later on the follow-up of this patient. But we really don't. I think we don't really have the PV outflow track at the moment.
And do you have pulmonary flow reversal or not? That's okay. I'm not looking for blunting. I'm looking for reversal. Huh? MR is moderate. That's to me. I know you have no baseline shift, but most likely it's going to be a moderate or somewhere there. The ventricle foreshortened, but looks like ventricular function is still good. That's why a transthoracic hemodynamic evaluation is important. I want to know what the size of the ventricle. The size could be small, and if you add a small ventricle to a more impressive mitral regurgitation, then you end up with low output situation systemically, and you get hypotension. Making sure that patient is not on any drugs that makes her, hypotensive. And I guess the big question here: would you do a clip to try to improve the situation? I mean, that's down the line what you want to think about.
Under what medication was the patient at this moment of the TE?
And what's the pressure like, right?
85 and 53. That's right.
No. Medication. Under what medications? I don't know. Adrenaline.
No, she was not supported. At the time, she was not supported. No. No vasodilator whatsoever. No, nothing. Vasoactive medicaments. But the next question that we wanted to ask is why did it get worse? Yes. So we have the platform ready. Anterior. Yeah, sorry. Okay. So, doctor, we wanted to ask you that question. Why do you think the MR got worse?
It's a little difficult here to, I'll tell you what goes through my mind. The first portion of the case, you show us torrential, wide open tricuspid regurgitation. The question is, that's what I would do in the overall evaluation as to what happened. Severe, wide open tricuspid regurgitation, which tells you that systemically the output would be low and the ventricle most likely would be on the smaller side. You fix the tricuspid valve, so I want to know what the systemic output in the LV outflow tract was, although I have atrial fib, but I can correct for the RR interval and know what the size of the ventricle is, what's the function. I want to know that portion. Then I fix the valve. RV gets depressed, may shrink a little bit, but certainly gets depressed. So systemic output most likely is lower. I look at the VTI of the RV outflow tract. I also look at the VTI of the LV outflow tract and see how do they relate to each other, what really happened. Now, you could say to yourself, why is the MR worse? Could it be a stunning of the ventricle? Is the ventricle actually bigger now because there is more systemic output going to the left ventricle and then stretching the papillary muscles and you have less coaptation? You won't know that unless you do the various measurements and try to compare what happened before to what happened after and what happened to the systemic output. So, if the ventricle size is about the same and function is about the same and I have more regurgitation, then my LV outflow tract VTI will be smaller and then I got hypotension, etc., etc. What I see is the LV looks like a decent size to a small, and ventricular function with all the foreshortening is still decent. So the MR may have gotten worse. I don't know if it is protection during surgery or something else that happened, but I would presume that in the absence of infection, meds that bring pressure, etc., that the systemic output is lower than what it was before, despite having torrential TR before, because the RV function got much worse after surgery. That's would be my evaluation.
Okay, but we make the measurements of the LV diameters and volumes, and if you take a look, the size of the left ventricle below is smaller than
Yes.
both of them.
Okay.
All the diameters, the angles, everything. So we thought, because if you have a discussion with the surgeons, they send the patient to change the tricus valve, and now the problem is in mitral valve. So,
Yes.
So what you don't?
What happened?
Yes.
Why are you not telling us?
The only explanation you have is that the ventricle now, the preload increase the diameter and the volumes, and in a huge atrium with some calcifications, this increase of the preload increase also the MR severity. This is our explanation, but obviously we are not very sure.
I have a different thought, and this is idiopathic restricted cardiomyopathy. Can you go back to the MR, to the CMR?
Sure.
There you go. So this is humongous volvic biatrial enlargement.
Yes.
So And there's transmural. How old is she? 60?
She's 60, yeah.
So why would someone have at age 60 transmural atrial MR, FGD? I'm sorry, that's not normal. What I think, I mean, just speculating here, is that we fix the tricuspid valve, we decrease the annulus of the tricuspid valve, and still the left atrium is huge. So you kind of pull over from left to right the mitral annulus, and when you do that, you worsen the geometry of the mitral valve. But to me, it also reminds me of the Mario case. I can't quote him because unfortunately he lost the case, but that was in Cleveland, and they fixed a mother in MR in a chronically listening patient. He didn't improve, and 10 years later she died. Meyer requested the autopsy, and it was restricted, we had to restrict it for hemopathy, and it could look just like that. It doesn't necessarily, I mean, when you go through Mario's paper from Jack 2016, you go through the whole algorithm, which I think Glenn has diligently done so far, and it's not big, it's not pneumocomatosis, it's not endometrial fibrosis for sure, this is not EMF. So the last piece of the algorithm is that, so if you pull, when they fix the tricuspid valve, you pull the septum left to right, you still have a huge, how big is that atrium on TT?
It's huge. I mean, like, they're big.
The left atrium is 43, it looks bigger.
Este es, right.
No, we want the photography on this case. But still, I mean, just looking at the MR, at the CMR, it's big. So that's something else that could have happened.
El puncher 6, ¿cierto?
To me, and I know we don't have the LVOT TBI, it's a very meaningful MR compared to the one prior.
Right.
Yes.
Right.
But that could be underestimated because of the right atrium is even bigger. So I think you're getting a little bit of foreshadowing on the
I mean, there's no question that the severity of MR is worse, and it is functional MR. If I look at the previous transthoracic, actually, not this one maybe, posteriorly the function was not as impressive. Your measurement, Gabrielle, was that the annulus was bigger after surgery, mitral annulus I'm talking about. Ventricle certainly was not smaller, was a little bigger. So I really think functional MR got worse in this situation, and the ventricle, since the ventricle was not very large, systemic output dropped, and then you get hypotension. So it's worsening of functional MR. I don't think you underestimated the MR before, but I think it got worse post. So Hector, I agree with you in a way.
So yeah, from that last exam, the TEE, we had a severe MR, and the next step or question that we wanted to address was, what's the next step for this patient?
See, another thing on your TEE, I know you didn't show it. I would have shifted the baseline for you to calculate, right? To calculate your regurgitation. And this one, conceivably, I'm adding to the hypothesis here, is conceivably, because, where's your annulus? Had you measured it, right, somewhere? Because your annulus is bigger than what it was before, maybe the atrium is also bigger. This looks more like an atrial MR as opposed to a ventricular MR. See how flat the mitral valve is? So that most likely got worse. If the annulus is larger and the atrium is larger, the left atrium, you have less coaptation of the mitral valve. There's no question that the MR is more significant. Don't be fooled by the two-chamber light, because it's going to always look very impressive here. Only if you want to look at something, you look at the proximal velocity. It's always going to look large.
So for the next question. You already talked about the possible mitral clip. So after this discussion, will you still be in favor of repairing the valve percutaneously?
As you know, atrial MR and ventricular MR, as I told you before, actually there will be a paper coming out this coming week in JACC Imaging on atrial MR, a position paper from JACC Imaging. Both of them are very load dependent. Load, ventricular geometry, atrial geometry, you name it, everything else is related there. And the big question also to you is, how significant is the hypotension? We're all clinicians, okay? And some people run pressures in the 90s. We don't know how this patient was, but if this patient has still good urine output, good renal function, good everything else, this is what you have to think as a clinician. I would be less alarmed, but if renal function is worse, whatever it is, if hypotension is clinically significant, then you have to address it. And addressing it in a situation of hypotension without conduction abnormality that would trigger a BIV pacing, without anything that you could do hemodynamically in somebody with heart failure, most of these agents will get her even more hypotensive. You have to go for an intervention, and I would do a mitral clip in her.
Sure.
So was that, I guess, the hypotension was clinically significant, I presume?
For her, actually, she recovered. The hypotension recovered during her stay. She was given leave, and she's currently on follow-up, but she stays at AFib still, and she has this severe regurgitation, mitral regurgitation.
Has not changed?
No.
And the hypotension is more of a low blood pressure as opposed to significant hypotension involving perfusion of organs, right? Remember?
Yeah, no, during her stay, the hypotension, she got resolved. She transitioned to outcare satisfactory, even though she had the last follow-up, she still had the MR, the severe MR, and the AFib, but she was, asymptomatic. Yeah, she was asymptomatic.
Asymptomatic?
Asymptomatic.
You could gradually inch your way with medical therapy if you can. A very maybe low dose beta blocker, anything, but you gotta be very gentle here.
One moment, please.
Wonderful cases. Thank you for putting them together.
And now, today is a special day. We have had many teachers during our academic training. However, there are few who will transcend and remain in our memory over the years. Today, Dr. Juan Felipe Vázquez and I, Camilo Andrés Calderón, have the opportunity to make honor to exceptional teacher, Dr. Gabriel Salazar, who showed us how from the basic concepts we are able to solve any puzzle and reach an accurate diagnosis no matter how difficult the case is. Thank you, Dr. Salazar, for all. Give applause.
queremos hacerle entrega a este reconocimiento. Dice de la siguiente manera: en nombre de los fellows del programa de ecocardiografía de la cardio, al doctor Gabriel Salazar por su invaluable contribución al aprendizaje y al desarrollo de la ecocardiografía en Colombia. Es para nosotros un honor decir que somos de su escuela, porque realmente creo que todos los que somos aquí egresados somos parte de lo que es usted, profe, y de lo que usted nos enseñó. Muchas gracias.
Dr. Zoghbi is bigger than yours.
Translate for the plaque, so Dr. Zoghbi. So it says on behalf of all the echocardiography fellows of our program, to Dr. Gabriel Salazar for his unparalleled contribution to the learning and development of echocardiography in Colombia. I think it's also a recognition to you, sir.
Eso quiero decirlo en español, que creo que me puedo expresar mejor en español. Después de escuchar todas las palabras que el Dr. Zoghbi nos ha dicho y de su experiencia de vida, yo no es que me sienta que ya estoy jubilado, ¿no? Creo que, porque generalmente esto se lo entregan cuando ya uno está prejubilado, no creo. Pero pues me llena de satisfacción y de alegría primero tenerlos ustedes aquí. Veo personas que desde hacía 28 años, ¿sí? Está Mauricio Jiménez, estaba Germán Pérez, nuestros primeros fellows y nuestros últimos fellows. Y pues yo creo que todos los fellows que hemos formado, cuando digo yo hemos, no he sido yo, ha sido el equipo que he tenido, han marcado una diferencia y creo que pues hemos contribuido a lo que en algo es la ecocardiografía hoy en el país. Ustedes saben que a todos los aprecio. Yo no soy como Medina, yo no soy tan expresivo, pero pues ustedes siempre cuentan conmigo como lo que fui, su profesor, y como un amigo. Entonces, esta es su casa, este soy yo, este es mi corazón, y muchísimas gracias por esto.